Okay, good morning, everyone, and thank members of the public and all those online. As you know, I'm the new chair. Well, I'm second chair now, so I'm Councillor Jill Slocum, so I think you've got used to me. The agenda pack with papers is available via the ModGov or directly from the Council's website from the link which was sent out to members. In line with the recommended meeting procedures, I'm requesting that all members and officers turn off microphones and videos, but please remember to turn on microphones and videos when you speak. This helps with the background noise, call quality, and anything disrupting the meeting. When I invite somebody to speak, could you clearly state who you are for the benefits of anybody who is listening to the meeting so they can identify who is speaking? Please, can I also remind committee members to use the chat function solely for business purposes only, as it's distracting to others and conversations going on. Can I warmly welcome any members of the public and media also to join us today? And finally, as agreed, our agendas are now viewed electronically. Could I kindly request that members and officers refer to page numbers from the published agenda pack to assist all present in finding the appropriate information? Thank you very much. Item 1 on the agenda is apologies. Over to you, Lane.
Thank you, Chair. I've received apologies from Councillor Stanton, Councillor Lawrence and Councillor Osborne.
Are there any others?
Councillor Govier, please. Councillor Govier.
Councillor Govier. Tony Robbins is online. Okay. Okay, thank you. Item 2 is minutes of the... Oh, so sorry. Sorry. Christine, is Councillor Lawrence?
Yes, it is. I'm just here online today. Thank you very much. I'll be here for a good hour with you. Thank you very much.
Thank you very much, Christine, and thank you for being here today.
Councillor Stanton.
Councillor Stanton?
Yeah, same. I'm here online.
Thank you. Item 2 is the minutes of the meeting held on the 31st of May, which was pages 7 to 20. Can I have your agreement? This is a true record, please, and you're happy with the minutes? Councillor Woods, thank you. Thank you.
The minutes, just much as I want to publicise one of my parishes, Stoke Subhampton, I think it refers to as Stoke in there, and it should be Stroke. The minutes. Just a plug for a PC.
It's all right. We'll get that altered. Thank you very much for that. We'll get that with the amendment. Everybody happy? Oh, all right. Sorry, this is some. I can see one hand. Councillor Stanton. A legacy hand.
Legacy hands.
Councillor Osborne.
Thank you. Just to say that I'm also attending online.
Thank you, Councillor Osborne. Thank you for that. Lovely. Thank you. Item 3 is declarations of interest. Can I invite all any members to declare an interest to make aware a list of committee members' personal interests, members of the district, town and parish council is available for inspection on the website. So do we have any declarations of interest? No, thank you very much. Item 4 is public question time. Do we have any? No members of the public. Item 5 is the mental health workshop. And I would like to thank the members who did attend. We were extremely poor on the ground, I might add, and which is very disappointing. We had 9 officers present from NHS, Mind, mental health team, and it was a really informative briefing. It wasn't a workshop, it was a briefing. And as you can see, all members were included in those slides. We had 2 ladies came along and they gave us a shared experience of their lives and pathways and the help of the mental health team, been able to give them and enrich their lives. And it was really very moving and very real because you hear people that have gone through a terrible journey and they were doing very, very well. All the speakers that spoke, and I said there were 9 of them, they were extremely interesting and they were very, very informative and it was very good. I think we have to consider mental health as everything we do. We consider the social detriments of mental health and consider how we engage and support those with mental health. health. I think those of us who are councillors especially meet residents probably every week who are suffering with these difficulties and finding coping with the world today difficult. We've said it would be good for some of the team members to come back for a committee space where we can monitor the hopeful improvements, bearing in mind their time is also very precious. So it's not something that we're not going to do. Mental health is going to be part of what we do all the time. It's going to be there so we can make sure we have briefings all the time. So I think everyone really enjoyed the morning, but I was disappointed the turnout was very, very low. And I think if we're going to have briefings where we get 9 special people come along and give us a really good briefing, then we need to ensure that we try perhaps to pick a different day. The date was changed, not by me, it was changed for necessity, but that's something we need to formulate later on perhaps. So does anybody else who was present want to say anything? Councillor Bruce.
Thank you, Chair. I would echo a lot of what you've said. It was really informative, but there was a problem for me in that I wasn't expecting a briefing. What I thought the committee had agreed and asked for prior to this was actually to have a working group set up to look at mental health services. We need to really sort of examine what services are in the county. Are they in the right places? Is there enough to meet the capacity? All those kind of questions that we didn't get answers to at that briefing, as you know, as good as it was, and I have to, you know, it was very good, but we didn't get those answers. I did ask at the time on the day if we could have a list of the officers who were presenting that day and which sections they were presenting for, and I haven't received that yet. I'd like contact details for them, please. And I think I would personally want to follow this up with, if there is appetite from other committee members, a small task and finish group. I did ask also, I think it's Andrew Keefe was going to provide some data concerning the services, because what was in the presentation was a very kind of high level. It didn't go into any detail. So perhaps it might be a start to get some data regarding the services that are currently existing that we could look at, and maybe some committee members might be interested in getting together and forming a small task and finish group to look at it still. I think it was just a start to me. That wasn't really, shouldn't end there.
It certainly won't end there, certainly not. But can I go to Mel, please?
So I would understanding.
Thank you. Sorry about that. So what it was a briefing for you to start with, about saying actually this is what goes on in Somerset in terms of mental health, and I think that was the starting point and the most important bit that we started with for you. Decided to work now. I think the challenge for us now is understanding what you want to learn and what you want to do as part of that. So if you do want a task and finish group, we need to be clear about what that is going to achieve, what we're trying to look at, because it's such a vast area, hence why they gave you a briefing of the whole. And it is about how we work with people with lived experience, and that's why you had 2 people here with lived experience, trying to share with you what it is and what they do and what their services are like out there. We can absolutely bring you data on all of this, but I'd want to make sure that I'd like you to be able to tell us what you want, because otherwise we'll be broad, and we need to be quite, because it's huge, we need to be quite specific. So if we do want a task and finish group, I just want to think about what the reason behind it is. Absolutely understand you want one, but what we're trying to achieve from it, what we're looking at, and then how do we make sure that I can bring the right people in the room with the right data set so that you can do that.
Come back briefly.
Okay, yes, okay, thank you.
Yeah,
Councillor
sorry.
Bruce.
That was my understanding, was what we were supposed to be doing that day. I thought was coming together to set some terms of reference for the working group. That's what I'd expected to happen. So yes, I completely agree that we need to set some terms of reference in terms of what we're looking at. I'll say from the start, for me, it's about looking at the services that are existing and seeing whether they're in the right places, they're accessible, and they're meeting the demand. What needs to be done, where the gaps are. And I'd also really like to look at how we manage changes in services when they are withdrawn or moved, how the process works for putting mitigation measures in place, and how we involve patients and their families and carers in that process. and maybe look at a case study to see how that's been managed and what we can learn from it and what we can do better.
Thank you very much. Councillor Woods.
Hello. I was disappointed having missed the briefing session, but I'd welcome notes from that briefing. Also, if we have those notes, it will give us the opportunity to feed back, perhaps just not online, but just feedback our thoughts on where we can go, so that we know what's going on, so that we can keep up to date, but not with another meeting. Some of us find great difficulty even getting online at times at the right time, which is basically what happened on that Friday. I couldn't get online, I couldn't get to the meetings. So I'd like to be able to feedback, but not in a meeting session. I think that's...
Councillor, I'm going to go, oh, I beg your pardon. Sorry,
Thank you. Well, I found the slides that came with the pack to be really comprehensive, and it asks us what we want, what you want from us at the end. So I think that's where we take the situation forward at this stage, I would have thought. I mean, I was starting from zero, and apologies again that I found I wasn't able to be there. So maybe there are others who are further down the learning point than I am, but the slides I thought were excellent and comprehensive.
thank you very much. And I did as well. And that's why we in to actually ensure that you were you know, able to hear, able to see very, very clearly.
Councillor
Councillor Stanton.
Thank you, Chair. Yeah, I was at the briefing. It was a superb briefing, but although the slides are very good, you couldn't get a feel for the content without actually being there, because these were really vivid exposés. I mean, opening their hearts by people who had experienced mental health problems and the service they got and the way they were dealt with. So it's not something you could write the best note in the world and you wouldn't capture the feel of the meeting. I wasn't expecting the same as Hilary was. I'm not against a task and finish group. I'm not offering to join it because I've spent most of the last year, as Mel knows, understanding all aspects of adult social care, including mental health. I'm pretty satisfied that it's being well run, but quite understand that others want to scrutinise that. So not volunteering, but not against our having a task and finish group.
Thank you very much for that. Thank you. Can I go to Councillor Lawrence, please?
Good morning again. I think we just need to look at the forward plan now, which we always do, making sure that this item is coming up shortly, as soon as possible, and therefore we can then come back to Mel and say, this is what we've done. Where would you suggest we start to look at the long-term work of mental health within our scrutiny group? So I think it does need to come back on a regular basis, because it is so important and we've all admitted it's important. So let's look at our forward plan, making sure that this item comes forward appropriately, and then ask Mel to prepare something that she feels will help us be sure that we're thoroughly as possible. Thank you.
Thank you, Councillor Lawrence. Thank you, Councillor Oakes.
Okay. Thank you. Thank you, Chair. Councillor Oakes from Yovleys. I'm a little bit concerned, and I apologise. I was ill, and that became impossible. I'm sorry that I missed the workshop, but I'm a little bit confused slightly by some of the comments. Our function as a scrutiny committee is to look at in depth at particular narrow issues. You cannot scrutinise mental health services in Somerset unless we go full time, 5 days a week for 6 mental days. It's a massive, massive area. However, there are areas of concern. I don't perhaps share Councillor Stanton's confidence. There are areas that are stronger and areas that are weaker. And I think if we were to, our function should be to look at those areas where there may be concerns, to find out why there are those concerns, and to see how that's going to be resolved in the future, because our function is there to review performance and to scrutinise and to dig. You've had the overview. We need to be far more narrow now. I think a working group looking at one specific area or two specific areas makes an awful lot of sense, but it does need to be a narrow issue because of the scale of this. This is not, if you compare it to, say, education, it's like you're looking at all the schools in Somerset, whereas there might be a concern about one. And I don't see our role to be, if we're going to scrutinise properly, we do need to be quite specific and look at a chunk of the service, which will still be quite significant in itself, but look at it in real depth and really boil down, because at the moment you've had a very useful workshop that gave you that overview, but that's for our learning. The scrutiny function is quite different, and we do need to be more precise.
Thank you very much. I'm also very conscious of the fact as well that there is a decision being made whether we go to monthly meetings. And I'm very concerned about monthly meetings in the fact that we need to ensure that we get the correct information to be here in front of members in that timescale, bearing in mind there are a lot of scrutinies. So that's another thing. So to try to fit a workshop in between, or a task and finish, or anything else, we have to be very careful. So what we can do, there's a way we can do this, and we're going to discuss this with Jenny and our clerk, because we need to formulate a process where we can do it. It's no good having loads of things on the agendas each time and we're not getting to the right area, the specific area that you want. I know, Councillor Bruce, there is a specific area where you've identified. You identified this at the meeting. I'm sorry that you didn't get the names. I thought you had. Because this was a briefing, it was an informative briefing where we all took notes ourselves. But we will get those, and I think the gentleman that you wanted to speak to did speak to you afterwards, and I think he did give you his contact details. He didn't, he said he would. So we'll get that sorted, because I think that Pacific area where you're on about does need looking at, but I believe it may have been looked at before. Councillor Ruddle, can you enlighten me on this one, or no? Am I wrong?
I'm not sure what actually we're talking about, Chair.
Okay, the hospital, St Andrews.
I'm going to refer to Mel, because Mel was.
Here we go. So what I would say is, and I have had this conversation here on more than one occasion, St Andrews is done, it's finished, it's sorted, it will close. That decision was made in September 2020. Thank you very much. Hey, look at that. September 2020, done, finished, sorted. If you want to then look at the services that are out there that support people in Somerset, we need to be really specific what we're looking for. So I'm happy to say, that's finished, that's done, that's gone, that decision has been made. As part of that decision making, we talked about, and the business case talked about, how we ensure that we have the right services locally in that area. When they came to talk to you the other day about what services were around, they really described open mental health to you. They described inpatient services to you. They described what the opportunities were, and as a system, what we were doing to support people with their mental health. If you want to check, are those services working? What is the numbers looking like? You can do that as a task and finish group. But the conversation around, is it closing? Is it not closing? It's gone. It was made in 2020. It's finished. What you may want to look at is what services are out there in that locality and in other parts of the Somerset, which manage people to live independently in their own homes with the support that they require, which prevents people going into inpatient units unless they really have to. And but your open mental health that they talk to you about is one way in which we do that, and we do that very well at the moment in Somerset, but we can share that with you.
Very much. That sounds, yes, that sounds really good. Thank you very much. Councillor Woods.
Yeah, I think I misinterpreted the slides that are here. I thought that's what we were going to discuss today, but the slides with the agenda are the briefing, or the ones that went to the briefing. And I was going to point out that I couldn't interpret the red, which was the bridge and St Andrews, which is, I think, what Mel has just answered. Thank you very much.
I think going
Thank you. We have discussed this before many times. We've come to the conclusion that there is nothing that can be done, nothing that can be achieved by regurgitating the same old disappointment that we've all got. We do know that there are beds that are being put forward for Yeovil Hospital. I believe it was 14 beds, if I remember rightly. So I think it's definitely time that we put on the agenda whether that is happening, how it is happening, the time scales involved, whether people are actually being able to utilise these beds, the transportation issues for family and friends around those, and all the things that come with it, whether it's being staffed well enough. And I believe that that is what we should be focusing on, and not constantly going back on something that we cannot undo. It is not in our remit or in our gift to undo that as much as we would like to. So please can we put forward a motion to actually, or whatever it takes, to bring that to the committee to look at all of those details that is what is replacing that service, please.
Thank you. Thank you very much for that. That sounds an excellent idea in line with what Mel was saying. Councillor Bruce.
I would second that. I wasn't asking to go back on the decision. And when I initially asked for this to be looked at, I asked to look specifically at St Andrews, and I was advised that we should look at the services across the county as a whole, which is why we went in that direction. So if that was the wrong thing to do, it was because I was kind of pushed in that direction, but completely agree.
The way forward is for us to look at the services as you very eloquently put, Mel, and we'll do that. We will put them on the forward plan at some stage. It'll always be something I think we need to revisit, not just the services. We need to look at the services as a whole, make sure everything's running smoothly, just have a briefing to come back here. And if we think there's anything more detailed, then we will obviously look to see what we can do. But thank you for the interest, Councillor Bruce, that you've taken in this, because you certainly have, and I thank you for being there, because your input was very valid on the day. Thank you very much. Everybody happy with that idea? Do you want to put that as a formal vote, or no? Are you happy for that to go on?
I'm seconding, I think, what the
Seconding.
motion was before.
So everybody all in favour? We just go. Everybody in favour of that idea? Like it across Somerset. Would that be, I think that's only fair, across Somerset. Yeah, right, thank you. Yes, sorry, Councillor, I'm so sorry,
That's okay. I agree across the whole of Somerset would be great, but we know that there are other services already working across Somerset. How well is to be debated at some point. But the specificity of St Andrews closing and Yeovil's 14 beds are very specific. And if they could take precedence within that, that would be preferable in my eyes, because obviously it brings about quite a lot of concern for the area where St Andrews was, and the local residents, their family members and friends. And knowing that everything is kind of on target for that being utilised as a service, people being able to, get there and back, it should take precedence over what we already have that is existing. But yes, look at what is existing to make sure it is still robust. Thank you.
Thank you. I think what we need is confidence. Confidence that when something closes, we need to have confidence that everything else is working well. And I think perhaps if that can start in that direction first, Mel, if that's okay, and then filter down, I think that'd be very, very good. So everybody, can you just vote again? Everybody happy with a slight little amendment there? Everybody happy? Super. Lovely job. Thank you very much. Right, now item 7 on the agenda is the primary care strategy. No, the work programme. I do apologise. Just seeing if you're all awake. That's all it is. Honestly, all it is. Item 6 is the work programme. And you can see it before you. Are there any comments, please? Everybody happy with the work programme? There will obviously be things that come up. We all know that. Life's not smooth. So there will be things that we can add or move around should the need arise. Okay? Hillary, sorry, Councillor Bruce, sorry.
Sorry, me again. Just the crime and disorder report. That's coming into adults and health, but I feel like it should be more of a joint scrutiny subject, perhaps with children's and community. I would have thought normally it would be a community scrutiny issue, but I completely understand it kind of involves all three of the scrutinies. So
I think we want to look at it here. I think it's good for us to have that here first, maybe last, whatever. But I think it's not a bad thing for it to be on this committee. So I think we'll do it this way for now. Everybody happy?
Mel, something to say.
Mel, sorry, Mel.
So it is something that normally does come here, but we can ensure that anybody can come to these committees, can't they? They can be invited in. It may be something that we go out and say, right, it's sitting here. This is where it will come to. This is the crime disorder. This is where it will sit. However, if others want to join that meeting, they're welcome to do so. I think that's probably the way forward with that one.
Thank you. Did you want to speak? Oh, sorry, Councillor Oakes.
Thank you, Chair. Yeah, Councillor Oakes again. I see that we've got in the sort of standby list the report back from the ambulance service. I'm expecting it to be late, but actually would think that it is such an important subject that actually having it instead of a workshop, having November, have a normal meeting. Looking at that, I wouldn't, because of the workload in September and October, some big issues in there. You've got strokes and you've got dentistry, which is not going to be a 5-minute conversation. So I would have thought if there was a November meeting, then that's the one the ambulance service would be expected to turn up if they got enough notice. They're failing to meet their response times. They might get here by then. It's quite reasonable they have the data. So if we had an expectation that if there is a meeting in November, that is the big issue that we look at again.
We
come back, I think.
okay, Mel, I'll go to you first because I need to explain something. Thank you.
So whenever we have the ambulance service here, that's fine. I would just like to point out that they are meeting some of their targets at this moment in time. So please, we have to make sure that we don't just say they're not when we don't have the data to tell us that. However, what I would also say is if you are wanting to do something in November, I'd really be pleased if we could also add to that our assurance, because one of the things that is happening in adults is we have assurance, we have inspection coming. And although we'll talk to you about that, inspectors will want to come here, listen and talk to you. And we may want to help each other understand what that looks like, help each other practice a bit of that so that we're all ready for them when they come. And that might be an idea for us to do that as well as have the ambulance service. So if you wanted to do that, that might be a really sensible thing, because they will be expecting of you certain things. They will be saying, actually, is this scrutiny delivering what it needs to deliver? Is it assured that? The inspectors will be looking, are you assured that you as councillors are really understanding adults, are assuring yourselves that the service is as it is? So I think we probably just could do with a little bit of work in that area to make sure all of you, when you're asked by inspectors, that you're ready and able to do that.
Thank you very much, Mel. Thank you. Sorry, yes. Councillor
Sully.
Sorry, Councillor.
Thank you, Chair. I requested suicide prevention, and there seems to be consensus on the committee for it to be in the work programme. And then I did see an email that was coming back in September, but I can't see it on here mentioned. Am I missing it? Is it me? Can't see.
No, what happened was I circulated a update report because the suicide prevention team said there was nothing new to come back to in terms of there's going to be a new strategy coming out, possibly November. But what we've also done in addition is proposed that we may have a briefing session for all councillors, which was something you wanted to do, and that may be coming on the briefing schedule for all the councillors for their training. But in terms of coming back to this committee, there is nothing new, and the update was to keep you abreast of the development since we last had it. And there is going to be a new national strategy, and when that came out, that was the point at which it might be more appropriate to come back to the committee.
So when we began this, what was it, a year and a bit ago, it wasn't even included on the work programme, so we included it. I just think I'm concerned if it's not on there at all because there's nothing new. I think that's a bit depressing to say there's nothing new with suicide prevention, because that's almost saying it's not going away. But I just feel like if it's out of sight, it's out of mind. Can't it be just at least mentioned that in September when a new report? I mean, not seeing it on there at all kind of worries me a little bit because I feel it's important.
I
Flat out.
Yeah, what we'll do is if we accept that, it's like, it's really difficult. There are so many great, important topics, really important topics that we need to talk about. We need to scrutinise as much as possible, but we also don't want to go over and have the same people coming with the same words that they said last time if they've got nothing to update us with. So I think we need to be mindful of that. But I think you're right. I think having it on the list will let us know that it's still there. We stood up a very, very important issue in our minds, so we'll keep that on the list, definitely. All right. As the ambulance service, I've had good reports from the ambulance service, so I'm actually quite, of course, we need to keep on that, make sure, but I've had some really good reports, and I think that's very encouraging. We need to know our response teams are doing well, and I think what we need to do is, whilst we're scrutinising, we also need to be encouraging as well to make sure that they know they're doing a good job. But I'm very pleased. Councillor, wait, John, sorry, I don't know why I forget your name. I'm so sorry.
He's not.
Man who's got a lovely coat. Thank you.
In relation to Councillor Oak's comments about the ambulance service and the standby list, I noticed there's also an ambulance service performance. And I would have thought, would it be appropriate, I'll ask the question rather than state, that we have those in the same position? Save their time, and also it seems to be appropriate anyway. So that'll be November, I guess, would it be? Thank you, Chair.
I think that's an excellent idea, and thank you very much for that. I think we're noting that all down. It's all being done, so don't worry, nothing's been forgotten. Okay. Okay, thank you very much. Now we're going to move on to item 7, which is the primary care strategy, which is pages 57 to 76. And I'd like to invite Michael Bainbridge to introduce this item and outline and give us a presentation.
Thank you very much, Chair. So this morning we've got myself, Michael Bainbridge, Associate Director of Primary Care. Oh, sorry, beg your pardon.
Thank you very much.
Thank you. Is that better? Thank you, Chair. So it's myself, Michael Bainbridge, Associate Director of Primary Care for NHS Somerset, and Dr. Bernie Martin, Chief Medical Officer. Do you like to introduce yourself, Bernie?
Yes, I am Dr. Bernie Martin. I'm the Chief Medical Officer at NHS Somerset. So I have executive responsibility in my portfolio for primary care services. We're really pleased to be here to talk with you about what our strategy is currently. It is a strategy that has complexity underpinning it, and the implementation will be complex too. Primary care is not a single entity. I'm sure you're all aware of that. We sometimes clumsily ourselves refer to primary care when we mean general practice. Of course, primary care, the constituents include general practice, optometry, dental, and pharmacy services. We, as an integrated care board at NHS Somerset, now have delegated commissioning for the full suite of primary care services, which is something that we're really excited about, genuinely excited about, because it actually gives us an opportunity to look at things in the round, to look at not just single entities, but actually to genuinely look to what it is that the individual component part can do together to make sure that the needs of local populations within Somerset are being met in a way that makes the most sense, not just from a service perspective, but more importantly from the perspective of the people who we're looking after. So Michael led this work, but it is truly a piece of work that has had engagement from all sorts of different stakeholders, and it's really important for us that, while in a sense we're the guardians of this strategy, it actually belongs to everybody involved in the delivery of primary care services. And those who need them. And our role really is to do our best to make sure that we're paying attention to what it is that we're hearing from the people who are closest to the issues, so that we can support, enable and empower those people to actually design, modernise and coordinate services in a way that, as I said, makes the most sense to the context of the local need. So thank you. I'll hand over to Michael.
Thanks, Bernie. We prepared a brief set of slides which were circulated in advance. Be very happy to run through those and give a very brief summary of what the strategy actually says before getting into the discussion, which obviously is lovely. Thank you very much. Which obviously is going to be powerful. And just to be clear, this is the first of 2 appearances before the committee. So today we're talking about our primary care strategy, a kind of strategic intentions in relation to primary care services. And we're expecting to come back in September and talk about the detail. And it'd be good to talk about exactly what detail you'd like to cover. We're completely open and transparent about everything. We've got lots of data and information. So we really want to make sure that we share everything with you. And of course, we can touch on areas of detail today, but before we sort of plunge into the detail of individual service areas, it'll be quite helpful for you to understand what it is in totality we're trying to achieve. So that's our plan. So if you are expecting lots of detail today, please don't be disappointed. Let's be clear about exactly what detail you'd like to cover when we come in September, because we can make sure that we absolutely get into the level of detail that you'd like to. Okay, so the first slide really gives us sort of an overview of what we're all about in terms of this strategy. And the first thing we did when we started the strategy was one of the first things that the integrated care system said we need to do. We need a new primary care strategy because of the level of concern about primary care services in Somerset, which mirrors the national position. Everyone's concerned about primary care services. So the first thing we did was to talk to people and say, what do you think are the problems that we need to solve? And people came up with a list of 17 problems. And whilst all those problems were valid, by doing some reasonably sophisticated analysis, we were able to identify that there's one core problem, which is a mismatch between capacity and demand. And you might say, well, you know, did it really take you 9 months to work that out? You could have visited any pharmacy or any GP surgery or any dentist and found that out. But it's quite important that we're very clear about the kind of hierarchy of problems, because there are lots of problems and there are lots of issues that people feel strongly about. And the danger is that if we tackle what are actually subsidiary problems, that we won't focus our energy on the main problem. So the main problem is this mismatch between capacity and demand, and that's been growing for a long time. That's a problem that's been emerging over decades. But it really crystallized during and after COVID for a number of different reasons. But that mismatch between the number of people seeking help from primary care services and the capacity of those services to respond, that is our core problem. And so we need to keep testing ourselves when we're thinking about what we're going to do. Does what we're planning to do actually respond to that core problem? Because it's very easy to become distracted. So, you know, just to give you one example, there are lots of discussions about the future of the GP contract and the GP partnership model. You know, should general practice be nationalised? Should all GPs be salaried employees of the NHS? But what's interesting, when you look at the different business models of general practice, they're all experiencing exactly the same problem, which is that capacity and demand mismatch. So in Somerset, we've got 3 different types of GP providers. We've got the traditional independent partnerships. We've got Symphony Healthcare Services, which is a wholly owned subsidiary of Somerset NHS Foundation Trust. And we've got one employee-owned trust, essentially the John Lewis model, which runs one practice. We don't have any purely commercial providers at present running GP surgeries in Somerset. But if you look at all those different models, actually they're all having exactly the same challenge, which is that the number of patients and the complexity and the needs of the patients are often in excess of the capacity to respond. So whilst the business model of general practice is of interest, it isn't the fundamental problem. And if we were to allow ourselves to put most of our effort into changing the business model, we wouldn't be addressing the core problem. And it's that core problem where we're going to get the benefit for the people of Somerset by addressing the central problem. So it's quite important that we have that sort of sophistication of analysis, really. The second thing is, and Bernie's already talked about enabling and empowering. It's very important that we don't have a commentary on primary care services and we don't sort of judge them from afar. What we need to do is to have a really honest and transparent conversation with the people who are closest to the action, and that is people using the services. So, you know, the NHS terminology would be patients, but you know, the citizens, the people of Somerset. What is their experience of primary care services now, and what's the experience of our teams that are providing primary care services? And it's not just the GPs and the dentists, but it's the managers and the receptionists and everyone else. Those are the people who are going to be best placed to work out the solutions rather than us imposing solutions. So it is about building trusting relationships, and that is essentially our approach to commissioning services. That's particularly relevant to pharmacy, optometry and dental services that we took on from the 1st of April, because we do have a relationship-based approach to commissioning those services. So it's about developing trust, and that is slightly different from other ways of doing it. There are lots of different ways of organising a healthcare system, as you know. So as I've said, it's a broad strategic framework. It doesn't give all of the answers. It's not a detailed playbook or a 5-year implementation plan. Some people have asked for that. So, well, you know, what exactly does it mean? But it's important that it sets out a model for understanding problems within, rather than giving detailed answers to every question. Having said that, having written the strategy and having gone to the Integrated Care Board, we are now working on a set of detailed delivery plans. So the first one is already complete, and that will be coming to the Integrated Care Board later this autumn. That's about access, and particularly access to GP services. So that one is complete, and we're now in the implementation phase of that. And I can talk a bit more about that. There will be other delivery plans in terms of investment, workforce, premises, integration, and the neighbourhood care model, and so on. So if you sort of, if you like, that's kind of the strategy summed up on one slide. But I'll just go through relatively quickly, if we can move on. Thank you. And talk about some other aspects before we open it up for questions and discussion. So, as Bernie said, we've talked to hundreds and hundreds of different people. One of the things we talked to people about was what their vision is, what would they like things to be like. And so this shared vision was produced from those engagement events. It isn't our kind of version of what we think the people of Somerset ought to think. It is what people genuinely said. And the key things really to pull out are the thing about a warm and caring environment. That was really important, that people accessing primary care services want a warm, caring welcome. And people working in primary care services want to be able to give that kind of warm, caring service. And of course, with service pressures, you see that, you know, that ability to provide a warm, caring service being degraded at times. So that sense of having a warm and caring environment is really, really important. That's something that we really need to pay a lot of attention to. Be explicit that that's what we're trying to achieve. We talked about time and space and empowering people, and actually giving them the time to come up with solutions to their problems, and deliberately building that into the way that primary care services operate. It's also really important that services are local. So there's local, well organised and comprehensive on one line. There's a lot in that. There's a lot in that sentence, but I particularly want to highlight local. So there is a school of thought that says the future is consolidation, and we've got too many primary care services, we've got too many small GP surgeries, we've got too many little pharmacies scattered all over the place. We need to consolidate, and that's the future. I don't agree with that. And our analysis shows that actually having primary care services that are rooted in neighbourhood and in place and in communities is the way forward. But that's quite difficult to sustain for a variety of reasons. And so that ability to have a genuinely local service is a challenge, but we're setting out stall out. That's what we want. So this is quite an ambitious strategy. It's not going to be easy to deliver, but we're quite clear about that need for localism in particular, something I'd like to highlight. And obviously at the moment there's a lot of concern about the future of pharmacy services in Glastonbury in particular. It's not just pharmacy in Glastonbury where that tension between local delivery and consolidation is playing out. That's a tension we see across all 4 primary care services and across the whole county. Thank you. So I'm just going to very briefly talk about some of the headlines from the 4 different services. So if we can go on again to give a kind of headline about GP services. So again, wanting to give real clarity about what the priorities are. One of the things we did as part of this work was to tot up the number of different targets that GP surgeries operate to. And I think we lost count at somewhere approaching 500. So actually helping people to see the wood for the trees and being really clear in Somerset, what are we about? What do we want GP services to really accomplish is quite important in trying to cut through some of that fog and complexity. We do need to simplify the funding flows. We need to simplify the contracts, but that starts with a clear vision of what it is that we're actually asking our colleagues to focus on. So there are 3 things, 3 really clear things. First of all, population health management, which is, you know, is a kind of a bit of a sort of buzzword term, but essentially it means trying to help the community that GP surgeries operate in to become healthier and not just dealing with the ill patient who comes in to seek help. And there's lots of things that we can do there. And it's fair to say that the population health capability of general practice has been degraded in recent years by the level of acute demand, particularly people seeking same-day care. So again, there's a tension there and a balance, but that ability to contribute to overall population health gain is very important. And so one example of that is hypertension, for example, high blood pressure. Lots of people with undiagnosed high blood pressure, and then when we have got people diagnosed with high blood pressure, they're not all receiving optimum treatment, and those play through directly then into adverse health outcomes, so strokes, death, and those are amenable to intervention. But in order to have that benefit to the population, we have to make sure that the practices are resourced and are clear about what it is that they can do, that we support them in doing that. So that's the first one. The second is continuity of care. And again, continuity of care is quite a hot topic. It's quite an emotive issue. There are lots of people that think continuity of care is an old-fashioned concept. It isn't. It's actually the core of the value that general practice delivers. So, you know, just to be clear, when we talk about continuity of care, we're not talking about a sort of an antiquated Doc Martin model of the village GP that's, you know, looked after 3 generations. We're talking about team-based, highly sophisticated continuity of care, where there's relational continuity where it's needed. There's informational continuity through a single care record, which is shared across professionals and across teams and across organisations. And there's management continuity. So there's a shared approach for everyone involved in that patient's care. And that continuity of care is extremely important. And again, that's come under pressure in recent years. And our conclusion is that whilst continuity of care is good for everyone, presently we do need to focus continuity of care on those people who can most benefit from it, which is people with complex problems. So that's not just, you know, older people with complex long-term conditions, although that's a big cohort of people who do need continuity of care. It's also people with complex problems at whatever age they are. So children with significant health needs and disabilities, for example, would be one group where continuity of care is really important. So we're not giving up on continuity care, we're maintaining it, and we're seeking to increase it. And then the third is about timely access. So people being able to access GP services when they need them, particularly making sure that we respond to clinical need, because in a situation where you've got more people trying to access care than the service is able to respond to, the danger is that we serve the wrong people, that we address people who perhaps have a trivial health condition, and we miss someone who's got a really serious health condition who's in danger of deteriorating if we don't see them the same day. So access isn't just a numbers game, although there is a target. So there's a target that everyone who contacts GP services should receive a same day disposition. So they should know that day what's going to happen to them. They shouldn't be asked to phone back another day, for example. That doesn't necessarily mean they will be seen the same day, but if they're clinically necessary to be seen, then the aspiration would be that they're seen the same day or the next day if that's appropriate. And then there's an ambition that everyone receives an appointment within 14 days. So everyone who needs an appointment receives one within 14 days, unless there's a particular reason why, otherwise, which might be about seeing a particular clinician, for example. And people often prefer to wait. Again, thinking about the continuity of care, people often prefer to wait to see a clinician that's well known to them, they have a relationship with, and that's important that we recognise that therapeutic relationship. So those are the three priorities that we're setting for GP services in Somerset. Thank you. So what stands in the way of all of that? The big challenge, going back to that capacity and demand mismatch, is workforce. So the easiest way to sort out a capacity and demand mismatch is to get a lot more workforce. So if we could have 100 more GPs tomorrow, we would welcome them with open arms. That's unlikely to happen, and in fact, we are forecasting a reduction in GP numbers. I'm sad to say that does put us in a poor position in terms of national expectations, because there is a national expectation that GP numbers go up. But of the 34 scenarios that we modelled in terms of workforce for the strategy, 26 of them showed a decrease in GP numbers. And even if we were able to keep GP numbers steady or even increase them slightly, we wouldn't be keeping up with population demand. As you know, we've got a demographic change in our population, which is leading to a significant increase in the proportion of the population that's over 60, and age is pretty much a direct proxy for use of GP services. So as we get older, we have more problems and we use GP services more. So if we wanted our GP numbers to keep up with population demand, then we would have been needing to significantly increase GP numbers 5, 10, 15 years ago and get that trend going. That wasn't what happened nationally. And so we're now in a position where GP numbers are challenged and will continue to be so over the next 5 years for the duration of this strategy. Having said that, it's not all bad news. We've been really successful in attracting international trainees. And again, there's a perception that if you're a doctor from Kenya, you wouldn't necessarily want to stay and settle in Somerset. That's proving not to be the case. We've got many great international doctors, and a lot of them are choosing to stay in Somerset after their training and settle here. Some of them are even taking partnerships. So that's really positive. Another positive is that we are expecting a significant increase in nurse numbers. And as you know, nursing leadership is as important as medical leadership in GP services. So we are expecting greater opportunities for nurses in general practice. And we've been really successful in increasing the numbers of staff working in wider primary care teams. So at primary care network or neighbourhood level, we've now got more than 270 whole-time equivalent new staff working in GP services. That's health coaches, care coordinators, GP assistants, clinical pharmacists, physiotherapists, a whole range of different staff who weren't there in 2019. So that's been a really significant and quite rapid change. If we can go on, please. Another important way of addressing that capacity and demand mismatch is through digital innovation, and so particularly helping people to get their problems solved as quickly as possible and as efficiently as possible. And in this, the NHS has got a lot to learn from e-commerce and the world of business. So if we think about GP patient websites, traditionally they're essentially a kind of a page that gives them information about the surgery, who are the doctors who work there, and what's the phone number, and then you ring up and make an appointment. Actually, we need to move quite rapidly to a situation in which the website is for those who are able to use it, and we have to recognise that not everyone is digitally enabled, doesn't have digital access, isn't digital savvy, but for those who can use it, actually trying to position those websites so that they respond to the service need that people have, so you get your problem solved online, without necessarily having to go and see someone face to face. So a face to face appointment is a deliberate consulting strategy where it brings real benefit to the patient by having that face to face time with a clinician, rather than the old fashioned model was it was the norm, you just got booked in to see someone whether you needed to or not. And actually a lot of things can be resolved online. A lot of things can also be resolved over the phone. A lot of things can be resolved through text messaging and so on. The other bit about that digital innovation is that we do need to help people not to end up in medical pathways where they don't need to be. So we've got some excellent examples in Somerset of GP services partnering with the voluntary sector. So SASP, for example, Somerset Activity and Sports Partnership. So a patient who seeks GP help with something like low mood, anxiety, weight management, muscular pain, joint pain, loneliness, isolation, rather than coming away with a prescription, they may well find that they're signposted into a group that's encouraging them to do health walks, for example, or go to a gym and receive some kind of health coaching and some training in what they can do to help themselves that will make a difference to their health condition. So while we do need to recognise there are lots of people with a medical problem that need a medical response, we also need to recognise that a lot of people that are approaching GP services actually have life problems that are very often best responded to in different ways, rather than kind of funneling them into a medical pathway. And that's particularly important in the current context where there's so much national emphasis on access to GP services, because what we don't want to do is stuff more and more people into GP services and increase the number of appointments. What we want to do is meet people's needs. And of course, some people do absolutely need to see a GP or a nurse or a pharmacist, but a lot of people don't. They need something else, and being able to separate people out and kind of signpost them effectively and navigate their care needs effectively is something that the digital innovation helps with hugely through artificial intelligence, segmentation of population need, and so on. So if we can go on, I'm going to try and speed up because I am an enthusiast for primary care services, and it is all really complicated, but the value in this is going to be in the discussion. So I'm conscious that I'm perhaps covering a bit more detail than is necessary. So we talked about the need for investment. We are investing, so we're just investing £800,000, for example, now in upgraded telephone systems for GP surgeries. So that will be moving a few practices, about 10 practices who are still on old-fashioned analog systems onto cloud-based systems, and they bring benefits like having callback technology, so patients don't need to queue. You can press the button to request a callback, for example, rather than hanging on the phone for a long time. So we will be spending money. Obviously, the NHS finance is constrained, so we need to be really smart about where we spend our money, and we also need to be really clear as a healthcare system where our priorities are. It's fair to say that the effectiveness of a healthcare system can be reliably measured by looking at the level of investment in primary and community care services. So the more a healthcare system invests in community-based services as opposed to specialist hospital-based services, the greater the population health outcome. That's what the international literature tells us. So it is important in Somerset that we have excellent hospital services, excellent specialist services. We do also need to make sure we have excellent primary care and community services. Okay, if we can go on again, please. So one thing I did want to just talk a little bit about is primary care networks, which are a fairly recent innovation. So over many years in Somerset, we've tried to help GP surgeries to organise themselves effectively in local areas, and we've called those things various different things, federations and networks and so on. The point is that a single practice with an average of 9,000 patients, there's a whole set of services that practice can provide. But if you have a bigger level of population, and most primary care networks cover around about 50,000 people, it gives you a whole set of other opportunities, and you can develop more specialist services. So one example is support for people living in care homes, which traditionally has been challenging for the NHS to get that right, and difficult for GP services, because traditionally you've had lots of people living in a home all registered with different practices. You've got different people coming in and out. Where primary care networks have been successful, they've set up enhanced health in care homes teams that are then managing the care for people living in care homes, bringing some standardization, consistency, reduced variation in quality, and actually a level of expertise that wasn't available previously. So that's one example of where that's made a big difference. So we think that local level of neighbourhood care is important. And the reason I mention that is because primary care networks are an artifact of the GP contract, the nationally negotiated GP contract. Kind of, if you like, that's how primary care networks are kind of created and funded. And that 5-year contract deal, which started in 2019, is coming to an end. So there'll be a new contract deal nationally with GPs. We don't know what that will look like yet. I think it's important for us to set out our story really clearly. We think that neighbourhood level of care is important. So whatever the national GP contract says, we want to have that local unit of primary care services organised in that way. Okay, if we can go on again, please. So that's GP services in a nutshell, and obviously lots more to talk about. But if we go on to pharmacy, optom and dental services, as Bernie said, we took responsibility for these on the 1st of April. And we've already started to set out our intentions with those 3 professional groups, and in particular to make it really clear that we want to have a relationship based on trust and a mutual service, a mutual commitment to the service of the people of Somerset. And that is perhaps slightly different to the way that those services have been commissioned previously, which has been on a regional scale, which inevitably has made it a less personal approach. If we can go on again, please. So I know that dental access is a real concern, both in Somerset and nationally. It may well be something that you'd like to focus on, particularly in our next appearance. Even though we've only been responsible since the 1st of April, we've already set out a very clear set of priorities. So we've got high ambition. So before 2013, with that NHS reorganisation, we in Somerset were commissioning a level of dental access that was appropriate for population need. So what that means is that everyone who wanted an NHS dentist could get one. So of course not everybody wants NHS dental care, so it's about 70 or 80% of the population. There's always going to be 20 or 30% of people who will prefer to go private. So there's no point in buying enough dental activity to cover those people because they don't want it. So we need about 70 or 80% population coverage, and we had that prior to 2013. At the moment, we don't have that. We're a long, long way off it. But our ambition is that we get back to that point where everyone in Somerset who wants to access NHS dental care can do so. And that's going to be a stretching target to achieve. And realistically, it's going to take us until 2027 to accomplish that. So this is a 5-year strategy. We're not going to accomplish everything straight away, but that's our clear ambition. In order to do that, we need to bring dentists back into the NHS. And there's certainly been a feeling in the NHS that dentists have turned their back on the NHS. But actually, interestingly, we talked to dentists, what they've experienced is the NHS has turned its back on them, and they want to do more. I think that one of the positives is that we've got a lot of dentists in Somerset who are saying they want to do more. They want to provide more services to the people of Somerset, but they need our help to do that because there are some difficulties for them in being able to do that. So again, like GP services, we want to maintain local services. It's very important that we do that. I think it's an important part of community life. The market town where I live has got a GP surgery. It's got a high street pharmacy. It's got a dentist. and it's got an optometrist, and I think we would want to keep all of those. It's very important. Those are very much valued facilities, very much seen as part of the community, and actually making quite a big difference to the health of the population. Again, that's not going to be easy. But one way it will be successful is through creative commissioning. So particularly for dental services, the national contract is a barrier in many ways. And it was found by a committee of MPs to be unfit for purpose back in 2008, but for one reason or another hasn't been fully reformed nationally. There have been some useful reforms that have been made, but we need to go further. And so that creative commissioning is particularly about commissioning additional activity that doesn't sit within the rules of the contract in terms of units of dental activity. And so just to give you one example of that, we've commissioned sessional activity for stabilisation. So these are patients who haven't had NHS dental care, they've had emergency treatment, but then they need something else beyond that. They haven't got a regular NHS dentist, but they need something more than a single kind of emergency treatment session. And so the stabilisation sessions give that patient a kind of a course of treatment over a period of weeks or months that actually stabilises their dental situation. They still don't have an NHS dentist at the end of it, but they're in a much better position. And that isn't transacted through the unit of dental activity aspect of the contract. That's essentially contracted on a sessional basis. So that's what we mean by creative commissioning, doing things in a slightly different way. And then finally, we have to increase the workforce. And of course, dentists are in short supply, we know that, but we do have some excellent examples of workforce initiatives in Somerset. So Yeovil College has been at the forefront of training, particularly dental technicians, and creating a training and career pathway. So people who start, if you like, in the most junior roles in the dental team, to help them to increase and develop their career pathways, so they can become more skilled, more senior members of the dental team. Again, a bit like GPs, it's not all about dentists, it's about the whole multidisciplinary team. And again, it's not just about the NHS care, it's also about, working with communities. So, yes, we need dentists to respond to people that have got dental problems, but we also need the help to help the population to have healthy teeth, which obviously is the goal of population health, to help people not to need so much kind of remedial dental work. So very clear set of dental priorities, big challenge. There's no doubt about that, in actually being able to deliver those, but we're starting off with a high level of ambition. Okay, if we can move on then, please.
I hate to, it's really interesting, and please, we could do all day with talking to you. I think this is the thing. I just need to speed this up a little bit, if I may. I want to give members enough chance. They have had the slides, so I want to give them as much opportunity to be able to ask questions.
To understand.
Thank you.
Yes. So we'll finish this off in about 60 seconds, I think, and then get into the discussion. So optometry. There are opportunities to do more on optometry, particularly urgent care. So diverting people with eye care problems to high street optometrists. So there's a lot of work to do there. And again, valuing the role of optometrists in our primary care setup and in our communities. Next slide, please. So pharmacy again is a big opportunity area and a big challenge. So there's challenges to the viability of the pharmacy model, but there's big opportunities, particularly to provide more clinical services through pharmacy. Next slide, please. So there's a set of priorities there. As the chair says, you will have seen those slides already. I'm not going to go through that in any detail, but we do have a clear plan for the future of community pharmacy in Somerset. Okay, next slide. So I talked at the beginning about this is an overview. It's a kind of a broad strategic framework. We are already getting into the detail of delivery plans. We've finished the GP Access recovery plan, and there's a whole set of actions there that go on from there. We haven't fully covered the whole kind of neighbourhoods and integrated care piece, which is very important. So this strategy is very much about primary care services in and of themselves, because there's so much that needs to be resolved. But obviously, it sits within the wider health and social care strategy. Okay, thank you very much. Thank you for your patience, and I'm sorry that I've
Oh, no, no, don't be sorry.
spent longer than
It
perhaps
is
I should.
absolutely, you've done an excellent presentation and thank you so much. I think this, we could sit and, like I said, talk to you all day long really, and many of the questions we want to ask. I mean, for us, before I go to members, is for us as councillors, the many things we get told is that people can't get a doctor. To wait 14 days for an appointment is just not good enough. And I mean, we talk about localism, we talk about keeping the local doctors, and then they're talking about combining surgeries together. People want their local people there, they want that accessibility. But I think for us, to have to wait 14 days to see a doctor and then to battle your way through the poor receptionist is dreadful for them as well. So I think it's really good to know that you're dealing with these aspects and you're actually getting to grips with this. It's very, very encouraging. So thank you. Can I ask members, is there anybody who would like to ask any questions, please? Councillor Bailey.
Thank you, Chair. Yes, an excellent presentation, and it's great to be carried along with such enthusiasm, really. I've got a question, maybe a comment about the third aspect of your, I think it was slide 2, but a while ago, the word access, and also the integrator situation. And it's a concern I have because basically people need to be able to access the system in order for you to know they're there and to whether they move into one of the other 3 areas, the other 2 areas, the preventative and treatment side. If you haven't got access to them, then they're never going to know where they go in there. And one of the key things I've found is that to access these services, they need to be able to get to them. And I'll just give a little example of where we found in Martock that because of very good, I'm sure, business reasons, the service were being focused into the South Petherton surgery as opposed to Martock. And there wasn't really anywhere for people to get from those 2. Having found that and knocked on the door was actually open. So we've been talking to people and we have generated an extra sort of service in terms of the bus service from the DRT side to be able for people to get from Martock to South Petherton. Along with that, lots of other things have been done, like increasing the number of appointments and people at Martock. So it's not just a silver bullet situation. But my concern is really that actually when plans are made, that these are thought of at the start rather than somebody saying, hang on a minute, there's a problem here now and we'll deal with it. And it's there now, but it was also there probably 10 years ago when the surgery at Petherton moved from the centre next to the hospital, and there was nowhere for people to get to it. They could walk to it, and so we extended the 81 bus to get there. So, but those all came as a sort of knee-jerk reaction as a result of things happening. And I would just hope that we could have those discussions, the wider implications of access, because it is the people who aren't digitally savvy, and there are let's be sort of perhaps pejorative about it, but they are in a certain demographic that need to be able to access the services and will therefore do it probably by telephone and probably by not their own transport as well. And it's how we can ensure those integrated links happen as well, because I could widen that into saying, well, there are things going on in terms of public health. And I think from the point of view of funding, perhaps it's something that the health team needs to think of, because basically it's quite easy to make those decisions if somebody else has got to cop the bill providing those bus journeys and bus services. And I think that's one element about the funding. But also there are wider funding if we look at things like, active travel, transport, etc. In terms of the public health side, which could all actually link together. And maybe there's a wider pot of money and resources. Money's not just the crucial thing. If we look at the public health situation wider, the health walk situation you referred to anyway, and somehow they're available somewhere else, but not all of them. So there's a couple of points really, just to try and crystallise the access and an integrated access, but also working with the other services that are in the area. And in Martock particularly, we had an Our Place initiative some years ago now, probably 8 years ago now, and that built up quite a network, but it's sort of been withering as resources have gone back. And so it's not necessarily, from your point of view, a need to reinvent the wheel. There might be just a need to reinvigorate what's perhaps been there, but has lost a bit of pace. So I saw the 3 points there: access, integration, and not reinventing the wheel, really. Thank you.
To respond?
Thank you, Chair. Thank you for the comments, and I think we would recognise everything that you've just articulated. One of the things that we recognise is that we are doing far too much in a reactive way, and a key element of what we're trying to do is to get upstream of a lot of these issues and improve the overall resilience, so that we're not layering a fix that you do in the moment today will get you to sort of next week. It's about us being able to stand back and actually take proper decisions that have a more enduring impact and make sense. Of course, we're doing that from a position of complexity and entanglement often. So there is something about how do we bring this strategy to life in a way that is useful and allows people to do that step back and to think properly about what it is that is needed, and that we don't do the layering on of individual short-term fixes and get to the root issues and the things that you're expressing about in terms of what we really have to give due consideration to in planning, and not that reactive, this is the solution today. But I think that's what we're about. But of course, that's not easy. So, but I think you're right. The example with those two practices in that particular geography is a really good example of where if you were to stand back from that and look at where things have gotten to, you probably wouldn't have designed it in that way if you'd been cognizant of all the things you need to pay attention to. So we need to get better at that.
Thank you very much. Can I go to Councillor Woods now?
Thank you. I could go on all morning with questions, but one that keeps coming round: how much are you working with the planning that's going on for building housing, for example? I first asked this question so long ago that I would be embarrassed to tell you when I was in Southmead, we were getting a lot of new housing coming on, but where's the doctors coming from? And we're told, no, don't worry, Rosemary, you'll get them when the housing's there. But people keep coming to me now and saying, you want to build all these houses, where's my doctor? So is there a way of looking forward rather than running around behind the situations that are developing, actually anticipating those situations? That's my one. The other one is a bit of a hot one. I'm a great favour, if you can afford it, let's pay for it. Now, that isn't very popular by some, but I know a lot of elderly people, if they're in pain, would pay to have those operations brought forward. But what do we get from the NHS? I go into Musgrove and there were signs up saying, if you have private healthcare, tell us. And when you tell them, they spit on the floor and move you down the list.
Well, I hope that doesn't happen. Very sorry to hear that.
Figurative
speaking. Thank you, Councillor Woods. I think we're talking about an increased population and the effects. I think that's what we need to have an answer on.
Do you mind if you go for it? Yeah.
Immense, really, but.
So on the first issue, Councillor Woods, we are all of us saddled with a national approach to planning infrastructure, which is, I think, suboptimal compared with some other countries. So there are countries that build the infrastructure first and then build the new houses. We don't do that in this country. We have a different approach. And so we're all trying to make that different approach work as well as possible. So it is imperfect. What I can assure you of is that we have very good relationships. Traditionally, we've had good relationships with the district planning authorities. We now have good relationship with the single Somerset planning authority. So we do understand where the new housing is coming. Obviously, there's an element of uncertainty in long-term planning because it's not always easy to predict with absolute certainty where new houses will manifest within a local plan area. But we do have the good overview, good liaison with planning colleagues. We do seek contributions for primary care services through developer contributions through the Section 106 process. that is challenging because obviously there are a lot of community infrastructure aspects that are candidates for Section 106 funding. And of course, our planning colleagues also have to deal with the viability of housing applications, the deliverability, and obviously, you know, the greater the developer contribution, the less economically viable the development is. So it is complicated. We are doing our very best with it. It is our statutory duty to make sure that everyone has access to primary care services. But what that sadly doesn't translate into is what many people would like to see, which is essentially, as you said, there's a new housing estate, so there's going to be a new doctor's surgery in it, and unfortunately, it just doesn't play through like that in a way that many people would like it to.
Much. Can I go to Councillor Pearlstone, please?
Thank you. Oh boy. I have taken lots of notes. I'm not quite sure where to start. First of all, thank you very much for your presentation. It's much appreciated. And I do desperately hope that what comes in September has lots of answers that many of us here would like to think that will come to fruition. First of all, I would like to ask about dentistry. You say you took over an awful lot of the care on the 1st of April. And I will declare a bit of an interest in this, in that I was due an appointment on the 14th of June, which I made back in January at a dental practice in Chard, which closed unbeknownst to its entirety of its patient base. I only found out due to another, a relative actually visiting a few weeks for their appointment a few weeks before, as you probably are aware. That was known as Roderick's in Chard. Chard is a large town. It is serviced, you know, it also would have serviced a huge amount of the population surrounding Chard. I don't live in Chard, and it serviced other towns and villages that didn't have a closer dental practice. Can I ask how, for Chard and surrounding, how that is going to be replaced in the future, as we know that, you know, basically I'm banging the drum on behalf of Chard councillors here, really, in that it was a major surgery in you know, major practice in Chard. And, you know, whether I get back on the books or not there, should there ever be a practice, is immaterial. But for the residents of Chard, who, you know, some do live in a deprived area and it is difficult to get about, the transportation links are poor. There are very few other options. As we know, most dental practices at the moment are now going fully private. And so it's becoming incredibly difficult. So the challenge of that is huge. I mean, it's a huge challenge, and I'm not entirely sure how you're going to come up with some absolutely phenomenal ideas that would try and combat what's going on across the dental system. So I look forward to that.
Mr. Bain, have you got?
Thank you.
Thank you.
I do.
Oh, do you?
I do, yes. I would like to ask mainly onward care. So when you're looking at primary care networks, are some of the pressures of increased demand due to the fact that patients aren't able to take up, there aren't enough referral slots at hospitals locally, you know, necessary appointments, that have those particular patients going back time and time again to their primary care network, causing lack of spaces for other patients, not to anybody's, you know, but simply because there's nowhere else for them to go if they're waiting for referrals for months and months and months, if they can get a referral at all, due to lack of, you know, consultants. And, you know, obviously consultants are dropping off, new staff are coming up that aren't necessarily expert enough. How are we going to combat that within the primary care networks? Thank you.
Mr. Bainbridge, do you want to just answer very small, or do you want to wait until give us something better in September? Not better, that's wrong, sorry. More detailed in September?
Well,
or are you happy to answer just a few?
I would like to say something about dental and the situation in Chard in particular, and I think Bernie might want to say something about the relationship between primary and secondary care and how we're dealing with, you know, waiting lists, for example, and patients in that situation. So the situation in Chard is very serious. We've seen 2 NHS dentists closing, and we also had the closure of GP surgery. So we've talked to a lot of Chard residents and people concerned with the community in Chard, and of course people are very concerned and anxious about the future of NHS services in Chard, and that's entirely understandable. What the strategy is trying to do is essentially 2 things. First of all, to arrest a deterioration in primary care services, and then secondly to build the type of integrated high quality primary care services we want. And that first priority is not, is not insubstantial. In terms of Chard specifically, we are working on a procurement to bring NHS dental services back to Chard. And we'd be happy to give more information about the detail of that, exactly where it is, at the September meeting, if it's helpful.
May I very quickly talk about the interrelationship between different parts of our system? So the example you're citing is around how teams work on the interface between primary and secondary care. I think there's a lot that we can do to help with that. It's not as simple as there being a straightforward capacity and demand mismatch. You've actually got, in a way, elements of capacity being utilised by the wrong forms of demand. You've got a mismatch between where a particular skill set, an appropriate skill set sits, and where with some of the way in which things are organised, you get the wrong flow of people to the wrong bit, and that just adds to the congestion and people not getting what they need. There's some really good examples where if you break from that sort of traditional handoff sort of model of primary to secondary care and actually work towards doing something in a much more integrated way, you can actually start to unlock some of that. A good example in Somerset is in West Somerset, there's a visiting frailty clinician who actually goes to that part of the geography in Somerset and just doesn't see the patient in front of them, but helps that primary care network to actually look after a particular part of that population, to help with some of the streaming and the directing so that people are getting the care at the right time from the appropriate skill set when they need it. That's just one example. That there is something about capacity, and the trust is working really hard to deal with things like the elective backlog. We're working really hard with with the council around what we're doing to improve flow out of the hospital at point of discharge. And I think if we can get things to align so that people are getting the right care when they need it delivered by the right part of our system, then I think that speaks to a certain sort of efficiency, which of itself unlocks capacity. I think that's what I'm saying. But there's a lot of work to be done to make proper sense of that. A lot of this is about professional leadership. So one of the key things I've been doing is bringing together the senior professional leadership in all parts of our system in terms of both clinical and care, and trying to work out how do we deal with some of these big questions. A lot of it is what we call models of care. Some of it's really old-fashioned at the moment, I'll be honest with you, very traditional. We need to help each other to break from some of that so that we're actually moving closer to the issues rather than handing them off to each other in a really clunky way.
Thank you.
Thank you. I am concerned that there simply aren't enough consultants to go around, and that is causing a backlog within GP surgeries with patients with long-term conditions or conditions that need that specialism, that are simply going back to their GPs over and over and over again because they don't have access to the limited resources, clearly, even across a multitude of NHS trusts, hospitals across the county and even outside the county. They're just appointments aren't available. And that will be having a massive knock-on effect on primary care services, surely. And, I'm really hopeful that secondary care can be worked on more robustly, I think. Thank you.
No, and I think it won't be the same for every specialty. So I'm a secondary care clinician. I'm a paediatrician, so I have some experience being a consultant in a hospital. I know that a lot of the time I'd been spending my time looking after children and families who just didn't need to see me. So there's something about, it's really important that we do match the skill set and capacity to where it's needed. There are some other specialties. So, you know, an orthopedic surgeon is the only person who can, you know, do a hip replacement. So that's a, you know, a very specific skill set that we need to pay attention to against that demand. But if you look historically, in the distribution of the medical profession, there's been a vast expansion actually of consultants in secondary care, and very little growth actually in primary and community care. And I think that of itself is driving some pathway behaviours that actually are inappropriate and actually are clogging up it's clogging up the wrong people being looked after at the wrong ends of the pathways often, and we just need to pay attention to that.
Okay, thank you ever so much for that. We've got a number of speakers, so I don't want to, Councillor Sully next, please.
Thank you, Chair. So you say that many patients are continuing to receive exemplary service and sometimes surprised at how quickly and well they're treated. So my question is, how are you not losing that? Because this is such a big, complex area that you're dealing with. And in my experience, and also my residents in my division, they're not bringing up problems to do with their healthcare in significant numbers. Now, may be reasons for that. It may not mean that they're not experiencing it, but again, in my experience, I've had great care when I've needed it. So how do you not lose that, and that we're not all talking about problems and then having a perception, and then you have to put words like, and they are then surprised? And the sort of second part to that question is you know, it's great to hear about the innovation, and there is a perception about innovation and digital divide, but it really can have an impact, particularly during COVID. Things changed on the way we access services, and it made things efficient, and it made you feel still that you were being served well with your healthcare. So yeah, so those two, those two questions. So don't lose, how are you not going to lose what is working well?
Thank you.
If you can just make it brief,
I'll try and give a concise answer, and it might be something we talk more about in September. I think how not to lose it is about taking a quality improvement approach. So being really clear about where things are working well. So for example, this year's GP patient survey has just been published. 100% of patients at Wells Health Centre said that receptionists were helpful. Okay, so you know that's a really good example, because reception teams are under real pressure, and that's one of the areas where we see real difficulties. So so what we'll do there is study what it is they're doing and make sure that other practices are able to learn from that. We do need to have a balanced approach, and primary care in Somerset is better than the national average on pretty much any measure. It's not perfect, and we can't be complacent. But with the exception of dental, which is a special case, for the most part, we do better than national average. But we need to maintain that. We need to support our primary care teams to be able to learn, and that comes back to having the time and space to be able to do that. Secondly, on the digital divide, it's a really important question, and you mentioned COVID. In a fortnight at the beginning of the first wave, we went from 5% of our practices offering video consultations to 95%. And you would never make a change like that in a fortnight in normal circumstances. And it was advantageous in some ways and disadvantageous in others. So I think we're really clear in terms of our expectations of access. We expect people to be able to access GP services online. We expect them to be able to ring and speak to someone on the phone, and we expect people to be able to walk in and talk to someone. And all three of those access routes are really important and need to continue. So there is a risk of digital exclusion, and we have to be alive to that.
Thank you ever so much. We've got one more person in the room. Oh, now we've got two more people in the room, and then I'm going to go online. But after that, I'm going to have to close this down because we've got a few more things on the agenda. So, Councillor Oakes, I'm going to let you go next because I'm nice.
Thank you, Chair. Yes, you are nice. That's official. Mike Rigby said you were, so I'm not going to argue with him. What we've been doing this morning. Can I first thank you for one of the calmest presentations about a crisis I've ever heard. You were very calm, suboptimal, brilliant. If you look at history, and I love history, when did this problem begin? 1948 was when the problem was, 47, when Bevan conceded to the doctors and created the problems we experience today. It's all that little Welshman's fault, because there was a compact. The British people were offered a deal. They were offered the welfare state and the NHS, and they embraced it. Majority Labour government. And since then, the NHS holds a special place in our hearts. However, the situation we're in today, whether it be dentists, whether it be GPs, whether it be nurses, whatever, is slightly surprised. Some of the way you talk about it as though it's kind of just kind of happened, and yet we have known for many years this was going to happen. My own union, the Royal College of Nursing, has been saying for the last 20 years there aren't enough nurses, and it was only 3 years ago that government said, no, there are plenty of nurses, and the doctors' unions were calling for more doctors to be trained. Oh, no, there's plenty of doctors. We've been badly let down, and in a sense you should get some flack from that, because you're the face of the government in this room. That we've been badly let down because they knew a deliberate decision was taken to run the engine on high revs and get by with the minimum, and it's not worked. And so the crisis we're in today, whether it be in dentistry, whether it be in any area of the health service, and sadly there's crisis in lots of parts of our health service, was foreseen, was warned, and was a deliberate choice. Not your choice, but it was a deliberate choice. However, the optimism side of it, the one thing, I mean, if you look at COVID, it was a fascinating time. More men died of COVID than women. But of the women who died, 3/4 of them worked in social care or health. A difficult time, but it did force change. And as you've just said, it did force change. The way that we've now got PCN teams led by nurses, working multidisciplinary, is better than what we had with GPs before. It is a better service. I was slightly surprised to get a letter from my local team saying they're taking August off. They're going on holiday. I've never known the NHS shut down, but they're shutting down for August. But a lot of what's going on in the health service at the moment is forced improvement. This innovation, this improvement is fabulous. But I wouldn't want anyone to get away from the fact that despite the very the excellent presentation and, like I say, that incredible calmness, the reality is that people like myself, I'm 63 years old, I had an NHS dentist for 62 years. I didn't choose to leave, they left me, and they've left everyone else in Yeovil. We have no NHS dentist provision for any new patients. We keep building houses and bringing people into our county. No NHS provision for them. There is a crisis, and I'm hoping that what is actually going to happen, and the chair kind of hinted at this, is that actually today we're just having an overview that we will look at the pharmacy system, we'll look at dentistry, with all the elements, but separately from today with the numbers, so we can drill down and look and see how it affects the whole county, and what your plans are in this very difficult scenario to make things actually better in detail. And I'm hoping, I see dentistry's down in October. I think we'll have a full house for that one. I'm hoping all the members will be here. As you guess, there's no real question. I just needed to get off my chest. I'm blaming you, although it's clearly not your fault.
This is really kind of you, Councillor Oakes. Thank you so much for this. This is really kind of you. Okay, and yes, and we want a full house every time. So members who are online now, who are on the committee, I want to see you next time. Some people can't be here, and I do appreciate that. But this is important, and we're now going into the deeper detail so we need everyone on board. So we've got one member in the room, because you know priorities to a member in the room, and then I'm going to go to Councillor Trimnell, who's been really patient, and that is the last speaker, if that's okay. So Councillor Bruce.
Thank you, Chair. Again, echo my thanks for the presentation, very informative. One question for you and then a few observations, because you asked about what more details we'd want to see coming forward. So it's probably a silly question, but this strategy has already been adopted. It's been brought to us now just to note that this is already in force. So that's my first question. And the second question is, how does the scrutiny process work for the delivery plans? At what point will we see those delivery plans? Are they going to be brought to us as a fait accompli and we just comment on them, or do we get to say and put some input into them beforehand? So that's kind of my first question, really. In terms of what detail I'd like to see, my GP I don't think of as a business. I think of my GP as my NHS doctor. But you're talking here about business models, different business models, and a business to me is a profit-making enterprise. It's highlighted to me that I need to do more research into how the GPs operate. But I would really like to see more detail in the plans in terms of what the existing business models are and what we want to move to, so we've got some comparison. I would also like to see, as was mentioned, more emphasis on how people can access services who are not digital. So that didn't seem to be mentioned. There was a lot of focus in the digital side of it, but not how you can facilitate people to access that are having problems. We're in a rural county. Access is not great for internet. Same day appointments. There was mention in the strategy about there being the demand for same day appointments. But actually what I've had in terms of feedback is that a lot of the GPs won't give you an appointment in the future. You have to call at 8 o'clock in the morning or use their app at 8 o'clock in the morning. And if you don't get in time, you don't get an appointment. And they won't give you an appointment for 2, 3, 4 days time. You have to do it same day. So that seems to me that it's coming from the GPs rather than coming from demand from patients. Then there's mention in the strategy about prioritising, and there's talk about some activities are going to be stripped away. So I'd like to see more detail about what those activities will be that will be stripped away. Very pleased to see mention of integration of services. That's great, be a massive improvement. I'd like to see more detail about the measure of continuity, and about the lack of GPs. I may be interpreting this incorrectly, but you're talking about increased leadership for nurses. So putting, and if I'm reading between the lines, it's we don't have enough GPs, so we're going to give some of the stuff that the GPs would have done to the nurses and the pharmacists to kind of cope with it, almost like a mitigating measure. But are we just accepting that there are not going to be any more GPs? We're going to have that reduction and we can't do anything about it? Or we're going to, what's the detail in terms of, does that 5-year plan, what are we going to do across those 5 years to make sure that we are going to get increase in GPs? So I'd like to see a lot more detail in that.
Okay.
Last one, very quickly, new funding framework. Very important to get details on that. Connected with that, I'd like more information about how you're calculating demand. So using projected population data, how are you maybe going to get more access to Section 106 funds, how that system could be improved. Definitely there's a massive problem in Bridgewater. The developments are just expanding, as fast as they can. So we need to make sure that that money is coming through from the developers if it's there. So I'd just like to see more about that mechanism, and the new funding framework, what it's going to look like. So I think that's it.
I'm not going to let you answer yet. You will get, but I've listed everything. So in a minute, I'm going to go through it all. I'm just going to go to our last speaker, if that's okay. And that's Councillor Trimnell online, please.
Hello there. Thank you for having me. I'm the opposition lead for public health, and so I do have an interest in areas of this. I'm particularly hoping that there'll be more focus on what's happening with pharmaceutical provision. We're asking more and more of our pharmacists, but we seem to be reducing hours for pharmacies. Pharmacies are closing down. We know that in certain supermarkets we don't have any pharmaceutical provision anymore, and hours are reduced. Sunday hours, I think it would be hard to find a pharmacy that was open on a Sunday. I'm sure there must be, but I just want to know what we're doing to improve that, particularly as we're asking more some of the more medical elements from our GP surgeries to go into pharmacies, such as sore throats and stomach aches and all of those kind of things. So is that being looked at? And also dental provision. You said that it was something like 70 to 80% of the population that required the NHS dentistry. Where we're losing dentists fairly often to the private sector, do you see a point of saturation in the private sector, and that will sort of naturally stop that happening, and we may get some settlement as to NHS provision in our area, please?
Mr. Bainbridge, I think was only fair. Thank you so much, Councillor Trimnall. Thank you for your patience. I've listed a lot of things, and I think it's only fair for you. So I've listed the areas, okay, so shout at me, no doubt you will, if I've missed anything. I think we talked about the wider implementation of access, and that covers a massive ground. That was Councillor Bailey who brought that up. That was a really good, because there's not everyone that is digitally aware and not capable. And I think the trouble is our society today is assuming that we all are, and I think that's wrong. I personally would like, I think this covers a lot of things about the detail on workforce. I want to know where these doctors, nurses, GPs, dentistries, where are they? When are they coming? I want to see some facts and figures. I'd like to see the proof of what you're really saying. And that don't mean I don't believe you. I just like to see a little bit more factual evidence. Okay. Dentistry is coming up in our forward plan for October. So please, we were okay on that one. Delivery plans and business models, I think that's fundamental. That's really important. Our GP appointment system, I think that needs an overhaul. That needs to have, for us to have some factual evidence that why people are going to GPs and not getting an exact appointment, waiting for weeks. That's not good enough. It's just not good enough, and that needs to be looked at. Activities that are going to be stripped away. Councillor Bruce mentioned this. What activities are going to be stripped away? We want to know why. Give us the evidence of why you're stripping them. Is it the right thing to do? New funding programme. We'd like to know a little bit more detail about the new funding programme. Where is your enablement going to happen? How are you going to be able to do all this? Pharmaceutical provision. We are looking at that as well, but that's a big topic for me and many people. The pharmaceutical companies, and there are some irregularities with some pharmaceutical companies. I'd like some evidence of the good ones. And I'd like some evidence about how many have closed down, how many, or not you personally, but they are closed down. How are people accessing pharmaceutical? Like I said, dental provision will always be there because it's a top thing on our list. So anything you want to just, so that's a bit, anybody, have I forgotten anything, anyone? I think I've got everything. I think I've caught everything, yes? Good. Oh, Councillor Bruce, don't tell me I've forgotten one.
Just the scrutiny process, that's all.
Oh yeah, and the scrutiny process, obviously we'll deal with that, the scrutiny process, where we want to have this factual evidence in here, and then we want to be able to scrutinise every detail. So that's quite a big list. I hope you've got it. It's a lot of homework for you to do. But I want to say we really appreciate you coming today and giving us such a very, very detailed presentation. But I think by actually condensing those areas down, we can actually get the areas what we want to do, if that's all right.
Of course. So it would be helpful if we can have a brief conversation about where we go from here. We're very keen to make sure you have the facts and the figures so that you can scrutinise us effectively. What we'd previously planned, or I think what we were expecting, was that we would present the strategy here today in that kind of overview, which we've done, and then in September we would give a more detailed update on all 4 services, so GP, pharmacy, optometry and dental, but that's quite a lot. And it sounds like you're expecting dental in October. Is that right?
We've got it on our forward plan
Okay.
in October, yes.
So maybe the September be an opportunity to cover some of those other areas.
Yes.
Particularly pharmacy, workforce, GP access, as well as making sure we've asked all the other questions that have been asked of us, and then hold off dental until October, because dental really is it is a biggie. Out of all four, it's dental services that are struggling the most. There's no doubt about that.
And if it would be more helpful, you could send information in if you want into Democratic, to send that in and to Jenny, send the information, some of the answers that we've got, and then what we can do is we can make sure the committee knows, so we're all furnished with that, and then we can actually say, well, I don't accept that, or I don't like that, or I love that, that's fine. You know what I mean? It'll help the process on, so that you don't under this spotlight each time, because I think we need to, it's such a big topic, and like I said, really, we could almost have you here all day and talk about from A to B, but it would be tough, and I'm not expecting that. So I mean, you'd be asleep by the afternoon, that's not fair. So, I think if we can do it in this way, that would be great. Is that okay?
Yeah, absolutely. I mean, we're happy to we're happy to talk for as long as there is about primary care. Recognise you've got a lot of things that you're scrutinising. I mean, the other thing, absolutely, we can provide information in advance, and we're happy to do so. But equally, we'd want to make sure that we field the right people. So, I think probably we'll make sure that we've got the right people in front of you. You've got the absolute detail. Obviously, Bernie and I have got a broad overview. But if we're talking about dental, for example, we'd want to make sure we've got our dental expert in front of you, and you can really kind of get into the detail.
That's what we're hoping in October, that you do that. So let's just go. Just another councillor, just a moment. Sorry. Councillor Pearlstone.
Just quickly, is it possible at all to have just even a brief? I appreciate we want to focus on the other three things in September, but should there be any news on dental, whether it be, practices opening or any success stories that you could bring to the table in September, just to give us an idea that something positive is happening, that would be really, really superb, but not necessarily the full gamut of information.
It's just that we have got this plan for October now. So what I'm saying is if we don't worry, because October's not far, then we'll get the full briefing then. So, but I can take your point. Okay, now, just oh, sorry, Mel, I beg your pardon.
What may be helpful is if we work together outside here and just be clear about what the ask is, because I think you've asked for lots of information, so I think we can do that. And I think the other ask was, when do you bring things? So this, yes, is done, agreed. What you're saying is scrutiny should come before that. So how do we, and absolutely right, how do we make sure the delivery plans are discussed here before signed off, in essence? So how do we get that model working in a slightly different way? But I think what we can do is sit down outside here with you and work some of that through. So how do we do some of that? Is that okay?
Thank you very much, Mel. Thank you. Lucy, is that Councillor Trimlow, is that is a legacy hand? Or you wanted to come back?
Oh, no, I am sorry. No, I didn't take it down. Apologies.
Yes, thank you very much. Thank you. Sorry. You're asked to note this primary care strategy, and you've scrutinised the delivery of the strategy and ensure that the changes proposed are delivered in timely fashion. We'll make sure about that, and in a way that maximise the benefit to people of Somerset. And I think that's what we're doing. So I want to thank you both for today. Really, really informative. Very, very good. You do have a lovely calmness about you. I can imagine if there was a fire in your house, God forbid, that you'd be really calm and collective and say, right, we're just walking out the house, and that's what you need sometimes in life. So thank you so much for this, because it is a really big topic, and we do appreciate it, but we look forward to seeing you again. Okay. Thank you both. Thank you very much. I'm now, because I'm looking after your health, I'm going to give you a 5-minute break. Okay. 5 minutes.
Just while we're waiting, could I seek a point of clarification about the last presentation? Were we being given it to just understand, and therefore it already been adopted, so our comments are really immaterial, or are we part of the consultation process? I wasn't quite sure with the discussion that went on about what was happening.
Mel, she's going to tell you the right way. I'm going to take, this is not recording, is it? Is it recording it?
It is recorded.
Oh, okay, sorry.
So
Over to Mel.
So I think I know that this has already been through the ICB board and was approved a couple of months ago. And therefore you were getting it, I think, for information. I think the point that you made quite clearly was, how do the delivery plans that sit underneath it make sure that they come here, not for a nod or have a look at, but actually you're involved in the delivery. And I think that's the change that we need to make. So what I agreed after the meeting, having a conversation with them, is I'll go and meet with them with with Jenny and others and just work through how we get that right. Because what they should do is come here first. You should be able to have a look at them, have a think through, add comments, and then they could go elsewhere for sign off. So I think we just need to get that model right. And so there's something for us to work through with the ICB about doing that. So absolutely. So thank you for that point. I think it's where we need to get to.
I would have said that but not quite as succinct as that, but that's what I was assuming. Councillor Bruce.
Yeah, this is just an extra little point really. In today's agenda pack, we had a summary presentation, and at the end of the report that was just before that, there was a link to the full strategy. I would appreciate if a full strategy could be included. If we're getting anything like that, please include the full documents in the agenda pack, because it was very easy to miss that and just take that. I know, it might have been obvious that the summary was just a summary. It wasn't a full strategy. It was very brief, but actually having the full documents in the agenda pack would be useful.
We're now, we're still waiting for the two councillors, are we? Can I start?
I think we have to start with that.
All right, okay, we're now going to,
More than 5.
we're going to start the afternoon session. Can I please welcome the Leader of Council, Councillor Bill Revins, to our assembly this afternoon. Thank you so much for coming. I look forward to speaking to you. Right now then, this is item 8, which is the adult social care budget, items page 77 to 88. And I'd like to invite Penny Gower to give a presentation, please.
Thank you. Are you able to put the presentation up, please? Okay, for those of you who don't know me, I'm Penny Gower. I'm the Finance Service Manager for Adults and Public Health. Okay, if you go on to the next slide. Today we're presenting the outturn position for 22-23, because I'm just conscious we haven't brought that to you before. And when this report was due, Q1 wasn't actually public, so we weren't able to share that with you. But the outturn position last year for adults was, the overspend was 15.4 million against a budget of 160.1 million. Now we can continue to see that the residential and nursing demands for beds were both higher than budgeted across both adult social care and mental health. We had a number of staffing vacancies within adult social care, which did slightly reduce that overspend, but unfortunately not quite enough. We also need to remember last year we had those 8 home closures, which had a financial impact of 1.2 million for last year. Okay, in terms of learning disabilities, we've seen an increase in costs across supported living. This is around being able to sustain the market. And we've also seen an increase in daycare, where this is to allow the carers a break and respite. We've seen this significantly increase since COVID. And just to flag here, the further ongoing risks that we're seeing reflected into 23-24 is we're seeing a both increase in demand in the numbers of people coming through, a slight increase, but mainly an increase in the costs associated with the permanent placements and around the market sustainability that's linked to that. Okay, if you go on to the next slide, please. So this is around the pressures and challenges that we're facing currently in 23-24. I should say this slide was produced in May. So this was before we've done the official Q1 budget monitoring. So here you'll see we're saying the pressure for this year is 12.8 million. But actually we're publicly going with 12.1 for Q1. So it has reduced slightly. So the part of the pressures for this year are around the Newton My Life, My Future project. So when the original 10 million was put into the budget, that was broken evenly across the 2 financial years, 5 million to be achieved in each year. That was because when the budget was set back in February, that was prior to us actually having the breakdown from Newton about the timelines of when things would be achieved. So that's part of the pressure for this year. We're also seeing an increase in learning disabilities. So this is around supported living and daycare, it's continuing on from previous years. We've also seen a slight increase in pressures with placements. So as you can see, I've put a table on here around the fee increases. So we built into the MTFP fee rates for residential, for example, as being £750, but the average that we're currently commissioning at is £894. And it's the same across all the board. All the rates are much higher than we originally built into the budget. Only 13 homes out of 150 are currently accepting our £750 rate. That's adding further pressure. We receive roughly 70 new placements requests a month that come through to sourcing. And since April, we've received 83 capital drops that have come through.
So for those that you don't know, a capital drop is where somebody has been living in a care home and self-funding, and then for a period of time, and their money then runs out or below the threshold for adult social care to fund that. And we're seeing that more and more. So as the price of care goes up, people's money runs out quicker, and therefore that translates to adult social care needing to fund it. So that's we normally looked at about 2 years for people to be self-funding. Normally, when somebody goes, they tend to have a look at about 2-year plan. It is going quicker, and that's a national issue, not just a Somerset issue. And that's because fee prices for self-funders can, in some circumstances where people are living, be higher. What we then do, just so you know, is we have a conversation with the provider. Some providers will then take it to our fee rate, but a lot of providers will say, no, we cannot take it your fee rate. Therefore, the individual may have spent 2 years living there, spending a proportion of their income, and we then have to move the individual. But that's a conversation we have with families, because we need to get it at the rate that we can.
Okay, next slide. So myself, Mel, and her 2 assistant directors last week went through the budget, adults budget, line by line, and have come up. This is just a snippet of some of the mitigations and actions that we are going to take forward for 23-24 to reduce the 12.1 overspend. So we're going to allow, we're looking into the providers charging us VAT. So at the moment, not many of our providers can charge us VAT, but they have to have a separate company. There's lots of rules around it. A bit complicated. I could go into it if you want to know, but yeah. We're also going to be looking to review the MTFP fee rates for 24-25. I've got a meeting tomorrow, so we're going to start to look at those fee rates for next year. There's a theme around reducing the over-reliance on bed placements, around redesigning the reablement service, looking into voids. So voids are for block purchases of beds. So have we got those beds in the right places? Have we got those blocks in the right places? We have already achieved a saving against some of the voids. But they're also going to review any high cost placements and complex placements with a review to gaining either joint funding or CHC funding. There'll also be some work done with our colleagues in the ICB around the system solutions, what money is available for us to solve it as a wider achievement. Also reviewing all interim placements. So this are people who may have come out of hospital on a short-term placement but have been there slightly longer than short-term. We are no longer commissioning these types of placements, so that shouldn't happen anymore. And also we're investigating the use of DFG. So historically DFG was sat in the districts, now we're all one. Let's look at the plan of the DFG. How can this be better utilised to reduce the spend in adults? Rosemary, I can see you probably. No, sorry, Jill, have you got a question?
Councillor Oakes would like to interrupt, if that's okay.
Can I just request that when we have slides and everything else, that the English is used? Because my MTFP has just dropped off of my void into my capital drop of CHC/JF.
Absolutely, that's fine. We'll take your point.
Yeah, no acronyms.
No acronyms going forward. Absolutely fine. Okay, if you want to move on to the next slide. So Mel, I thought it'd be good just to bring in a benchmarking slide, which indicates, so as you can see, Somerset is on the right-hand side. We are, our average cost or unit spend for adults 18 plus, we're ranked 16 out of our statistical neighbours, so we are the lowest. Our costs, unit costs are 11.2% lower than our nearest neighbour, and compared nationally, our unit costs are 14.1% lower than average, and we're ranked 104 out of 125. So just to add some context, Mel will come in here.
So what we know is you will all hear people saying, gosh, you're spending all this money on adult social care. Surely you can make some savings here. Surely you can do things differently. We have done an awful lot of things differently, hence why, and when you look at the benchmarking information is our nearest neighbours. They're the people that are statistically nearest to us that we support, and it's a group that we always use. Our benchmarking is low, and that's low on a nationally and across our nearest neighbours. Therefore, it is really tough for us to keep finding lots and lots of money in adult social care. The reason we asked Newton to come with us was so that Newton, who are our leaders in this across the country, can look at adults, can examine where we can make additional spend and additional savings. They've done that, and hence we're now building that into our savings going forward. But I just wanted to share with you where we sit. So often you think higher is better, but higher in this instance is the opposite way round. So just to make sure you're aware of that. So ranking 144 means we are 144 lowest spend on adult social care in the country compared to 125 authorities that are out there. So I just wanted to share that with you as part of this benchmarking. So you're starting to get some understanding of where this budget is, where it sits today and where it needs to be. As we've said, is the budget currently is 12.1 million overspent. We have got some mitigations in there to bring that down, which we are working on a weekly and daily basis. My teams have got targets to hit in all sorts of areas to try and reduce it. The challenge we have, and working nationally, is the funding for placements for adult social care is going up and up. We know interest rates will have risen. I don't know if they've announced yet, but interest rates probably will rise today, which is a problem for our market, for people in it. We know cost of living is rising. We know the next year we have national living wage, etc., etc. So what we wanted to try and show is actually government at this moment in time, when we're working with the Department of Health and Social Care and looking at what is the cost going forward of inflation, etc. We're looking at probably an 8 to 9% rise in costs for our providers going forward next year. We're working that through at this moment in time. We're just seeing what that could look like. But be aware that this isn't a budget that will reduce rapidly. It's a budget that will grow, but government are giving funding to do that. Not enough, but they are giving funding to help us in that way. And I will open.
Thank you very much, Mel. Thank you. I think it's always worrying when you hear the budget's down, because then you think we're not spending enough on adult social care and we need to spend. We don't want people to be. So it's a sort of a strange thing, really, when we say we've got to reduce it, because then I feel that we're not giving people the service they deserve. So I was feeling in two camps here. It's a very difficult one, isn't it?
It's about saying, actually, now we are a unitary authority. What is the way in which the rest of the authority can support adults? Because actually we can't do it on our own. So it's how are we augmenting the care that we need to deliver by using the community, the voluntary sector, and people, carers, etc. in their local communities. And I think that's the change model. There will only ever be so much money. Therefore, we have to make some difficult choices. Therefore, we have to make sure that our communities are supporting in whichever way they can. Bearing in mind, we then also have to support the carers. So, let's give you, you can't ask people to do more and more without supporting those voluntary sectors to do more and those communities to do more. And we know that is already happening in Somerset. We have a fantastic voluntary and community sector mobilisation to support us for people who are living in their own homes. I think the other thing is we know that people will need nursing care at some stage in their lives, some people, but making sure we have that in the right place, but making sure there are other models of delivery, so other ways in which we can support with housing. So now housing are coming together with us. What is our housing strategy for the future that enables people to live independently? So that's the other piece that we'll be working together on over the next few years, so that we keep people in their own homes as long as possible.
And I absolutely, that's the way forward, absolutely. Thank you so much, Penny, for giving us that detailed budget. Can I go to Councillor Bailey, please?
Thank you, Chair. I'm not sure whether you're taking questions now or wait. Okay, fine. It was just a point of clarification on this particular benchmarking slide. What was the period over which it was taken? Was it a year or just a snapshot or what?
1 year, so it was taken from, I think it was last year's costs.
22, 23.
Yes.
We have it every year. We're either 104, 106, or within that region. We're down the bottom end and have been for the last 4 or 5 years.
Chair, would it be possible that we also in the future have a graph that contains all of the 125 authorities? Because I think the extremes would be worth viewing.
That's all right. That's okay with you.
Yeah, we'll certainly get that information. I don't think they have a graph, but I'll get the information so we can just compare.
Yes, but please give him a graph, otherwise.
What we can do is show the extremes at either end. So what you've got here is the national average. What you've got here is where we are. What we will do is give you the extremes, so you've got the cost at both ends and the average, rather than doing you a graph with every. And if you want to know who the lowest is, we will make sure we give you that as well. Okay.
Right, thank you very much. Councillor Bailey.
Did I have a question? Have you finished now? Right, thank you. Excellent presentation, by the way. And thank you for reducing the TLAs, or 3-letter acronyms. There was just one general question, really. Bearing in mind, and I'm looking at the outturn slide particularly, when you've got an annual budget and they're all based on that, it's quite difficult sometimes to compare month on month. Do you do a moving annual total? And is that what the month 12 variance means? In other words, you take a month off and add a month on, so you're comparing a year with a year and not looking at just the little peaks and troughs.
Okay, so the month 12 variance is just the variance, so it's out at the final year projection against the current budget. So if you look at the movement from month 10, so that's where it's moved between the months on the fifth column along.
Yeah.
So that will show where it's moved between the 2 months. But the month 12 variance is just the outturn position versus the budget. That explain?
Yeah, no, well, it does actually explain it, but what I'm thinking of is how we get the fluctuations within a year smoothed out by doing a moving annual total. So basically, you just take 12 months by taking a month off and adding a month on all the way through. And do you do that?
We don't currently do that at the moment, no. But that could be something we look to do.
Yeah, I just wanted to just have a look and see whether that'd be beneficial. Because, well, anyway, for the reasons I've just described. Thank you.
Thank you very much. Councillor Prostam.
Thank you very much. I'm just looking at the outturn, and one of my little areas is learning disabilities. So I'm seeing that Discovery, the current budget is 29.8 million. The 4-year projection is 27.8, saving of 2 million, which is great news. Can I have a bit more information about, generally, first of all, the overview of how Discovery work and how that 2 million has been saved? And is that likely to be realistic as a projection, given the fact that we're actually in that cost of living crisis and all of those increases in,
So this is outturn. So outturn is final. So that's what they did achieve. We expected that achieved. They have made part of the contract arrangement we had with them was to make savings year on year on year, which they have been able to do and have achieved. And some of that is because we're changing the model of delivery with them around block to spot and different ways of working. So we've done that with them. What I would say in terms of Discovery, Discovery contract now is running the best I've ever known it. We have had, and you don't hear the noise that you've heard in the past. So I think we've had a new manager there, director there for about 3 years. I'm guessing it's a 3-year period she's been there now about. it has made a significant change.
Fabulous.
Families are finding a very different way of working, and it is a different model of delivery now, and they're moving forward and they're changing the way in which they've done, and they've done that quite successfully. You will see that from the way in which they have changed with CQC. So in CQC in the past, they had quite a few, and Bill and we've talked about this on many occasions in the past, they had quite a few challenges in the way in which their services were running. They've improved a lot of those going forward. So yes, but we can have a separate conversation about discovery with you if you would like that at a separate time.
Thank you very much.
Councillor Bruce.
Thank you, Chair. I think I might have understood correctly. In the budget report, the page which is titled Pressures Challenges 23-24, that is the projected situation for this year and next year, right? Newton saving is projected to achieve 0.2 million instead of the 5 million that was built into the plan. It might be, do we need to have an update in terms of the projected savings from Newton? Because that's a very, very big change. And does that affect some fees that we pay them and things like that? Just like to have an update in terms of what the position is with the projected savings from Newton now.
So we always expected Newton to bring 0.2 in this year. In the paper that we took to execs, we were quite clear that what we wanted to do was get 5 this year, 5 next year. As we worked that through, we knew that you couldn't achieve everything straight away. You have to do that change piece to be able to achieve the savings. So in the paper that we took to execs, when we agreed to bring Newton in to us to help us with the delivery, we agreed at that point that we would make 10 million within 2 years. What we did in the February beforehand was build 5 and 5 in each year. What I can do though, and thank you for asking, what we will do is bring the Newton My Life, My Future. Gosh, I'm glad you lot are remembering. It's a name that it's a name that we went out to talk to our carers, etc., about what they wanted to call this project. So a name that I've got to get in my head now. But what we will be doing is we take the programme initiation document, which has all the milestones and the deliverables in it, to the transformation and change board, transition, transformation and change board at the end of August. I am then more than happy to bring that back to yourselves here a bit later on, and then happy that you monitor that as part of our budget. So one of the asks of all scrutiny committees is to manage and look at our budget. I would expect that to form part of that managing, looking at that budget. So yes, please have a look at it, scrutinise it, challenge it with us. So what I would say is Newton are part of us. So if it goes wrong, it's as much my fault as it is their fault. It is a combination. We work together in partnership. You can't have somebody coming in telling you we have to do this together. So it is a partnership. So yes, we'll do that together.
Thank you very much. Councillor Bailey.
This is not a trick question, but could you just remind me what the name of the project now was?
My Life, My Future, so my colleagues.
Oh, just the two, yeah.
Just the 2 words.
MF.
My Life, My Future. We're not going to do acronyms.
That's a
No
full letter
acronyms, otherwise I'll think you're talking to me, so yes. So
Councillor Bailey, we have banned acronyms from today. No more acronyms. Okay, everyone. I just would like you to note the adult social care overturn position for the 22-23. Obviously, with the extra monitoring that obviously our good friends to the right have agreed to do. Are we all happy with that situation? Everybody agreed?
Content, yeah.
Everybody, can you show things? Thank you very much. And hopefully we'll get a bit more money. That'll be great. That'll be great. And thank you very much, Penny. A great job. And Mel, of course. Item 9. Now we're going on to item 9, which is the adult social care assurance report. And we go invite Nikki Shaw.
No, I'll do a quick presentation if that's all right, Chair.
Will you look, I'm sure as nice as Nikki, so yeah.
And we will let Nikki continue on because it's her great work.
Thank you. Over to you then.
Thank you,
Councillor
Chair.
Ruddle.
I'm very pleased to present the assurance and annual report to you today. The scale of adult social care is huge. The social care is an essential part of the fabric of our society. It enables and transforms lives. It supports people to live their lives in the way they want to lead them and where they want to live them. We want social care to help people stay healthy, happy and independent. Social care affects adults of all ages, including young people moving to adulthood and all those working at age with diverse range of needs. Care and support covers a wide range of activities to promote people's health and well-being and supports them to live independently, staying well and safe. It can include personal care as well as a wider personal support to enable people to stay engaged in their communities, live their lives in the way they want. Not only do we look after residents, we have a very strong employers focus around an effective workforce, workload, training, good practice, and a strong positive culture. And I would like to thank all the workforce for their continuing hard work. I would just like to finish on a happy story on how adult services can change a resident's life. One of our residents recently turned 105 years old. She celebrated this milestone birthday with her family and friends in her own home. Earlier this year, she spent weeks in bed and her health declining as she could no longer get out of bed safely. One of our community occupational therapists assessed her and procured a hoist and a reclining chair. This meant that she could once again be upright to talk to her family. Her nephew said he can't express what a change this has made to her life and to her health. She is healthier and she is happier. This is one of the many stories where what we can do is transform people's lives. Thank you, Chair.
Thank you very much, Councillor Ruddle. It's always good when you have a shared experience. Something like that, just it brings it home, doesn't it? How good things are. Okay, I have a question before I go to anyone else, and I wanted to go on the complaints. I wanted to ask you a question about complaints, if I may. What happens with the 4 remaining opening complaints, as in March? This is on page 35 of the book, sorry.
If I just help you out, and Nikki will come and do a presentation on the whole.
On the social care.
Yeah, Nikki will come and do a presentation on the whole for you, which will pick some of that up. But just for that one, we will always have open complaints, because sometimes if we don't manage the complaint at stage 1, and they're not happy with that, it will move to stage 2. And then it can go on to the Ombudsman. That's the rules that we have. So you'll always see some open complaints that we're working on and they're working with individuals about. But are you okay, Chair, if I hand over to Nikki to just go through her presentation as part of this process?
Certainly, please do.
Thank you very much. And thank you, Councillor Ruddle, Chair and member colleagues, for giving me this opportunity to update you on assurance activity across adult social care. Hopefully you can all hear me clearly, but do let me know if there's any problems. My name is Nikki Shaw and I'm a strategic manager in adult social care with responsibility for quality, policy, performance and assurance. We were very conscious that you have with your agenda today a number of very detailed reports associated with this item. So what we have tried to do is create this overarching slide set to just try and help clarify some of the key messages we wish to share for your scrutiny and discussion today. Councillor Ruddle has very helpfully outlined a little bit of an introduction to adult social care, but we thought it's always worth us taking the opportunity to remind everyone of its broad remit and focus. The scale of adult social care and support is vast. It affects the lives of over 10 million adults of all ages in England, with a new Skills for Care report published last month that revealed that the total number of filled posts in adult social care last year was estimated at 1.635 million, and that represented 5.2% of the total workforce in England, more than the number of people working in the NHS, in schools, or food and drink manufacturing. As Councillor Ruddle outlined, people draw on care and support in different ways and at different stages of their life. Some people will require care throughout their life, whilst for others, their needs may develop either suddenly or gradually. So, for example, some people may only need social care support for a very short period, possibly after a hospital stay, for example. We often assume that adult social care concentrates simply on supporting the elderly, but of course, in reality, it supports adults of all ages and with a diverse range of needs, including autistic people, people living with a learning disability or physical disability, people living with mental health conditions or dementia, and other long-term conditions. And so care and support covers a wide range of activities that ultimately serves to promote people's well-being and aims to help them to live independently, staying well and safe for as long as we possibly can. It can include personal care as well as wider personalised support to enable people to stay engaged in their local communities and live their lives in the way they want. When it comes to providing social care, as Mel has indicated a few times during this meeting, it's really important that we reinforce we don't work in a silo. Help may, of course, be via the local authority, via the council, where we have responsibility for assessing people's needs and where people are eligible, funding their care. But separate to the incredible support provided by many unpaid carers, the majority of social care services are in fact delivered directly by independent care provider colleagues that we may commission, which are mainly for profit companies, but also of course include our voluntary and community sector organisations. Many people will have care organised and purchased by the local authority, but others may employ individuals or personal assistants directly to help them provide their care and support. You will see on this slide that we have a number of duties as adult social care, and those are largely set out under the Care Act 2014. They encompass things like the provision of social care assessments and detailed care and support plans, the duty to meet the needs of someone assessed as being eligible for care and support, and undertaking financial assessments. But we also have duties around providing preventative services and information and advice that help to reduce, prevent, or delay people's needs for care and support. There's also duty there on the promotion of individual well-being and on integration between health and social care services, seeking to integrate our commissioning offer wherever possible. We have safeguarding adults duties, which include hosting a Safeguarding Adults Board partnership. And we also have commissioning duties in relation to market shaping, making sure that the care market is of sufficient quality, choice and sufficiency. And when providers independently are at risk of failure or closure, we have a duty to step in and support around provider failure. So this slide was just outlining, as Councillor Ruddle outlined, the breadth of cohorts of individuals that we may be working with. But when it comes to understanding social care, I'm going to aim to show you over the next few slides a fairly simplified flow diagram about how people access and receive our services. And I think it's really important to recognise that everything starts and ultimately, hopefully, ends within our local communities. Because the aim wherever possible is to ensure that Somerset residents have the opportunity to live full and happy lives at home and in their neighbourhoods. And that's why it's a key part of our focus on promoting people's well-being and helps to explain why we invest so much time, effort and resource on trying to strengthen our community and neighbourhood offer and work really closely with our third sector voluntary partners to help us achieve this. And of course, you heard earlier from Michael Bainbridge about that shared health focus as well on integrated neighbourhood care. But there will inevitably be times when an event occurs that requires people to seek more formalised support and help, and that brings them into contact with our adult social care services here in Somerset. This may result in them contacting Somerset Direct, which is the council's front door call centre, for some information, advice, guidance or support, or perhaps it requires them to be admitted into one of our acute hospitals. For those people that require it and cannot be supported within their local communities, this is where our adult social care assessment processes really come into being, which will look to establish a person's strengths, wants and needs through that assessment approach. People who draw on care and support have told us very clearly that the core purpose of adult social care must be on helping them to gain or maintain their own independence, allowing them to have as much control over their own lives as possible. So our care and support services really aim to support individuals and help them to retain or regain their skills and confidence, and wherever possible, prevent or delay their needs from continuing to develop. When care supports people's independence, it really allows them to have real choice and control over the things that matter to them, and ultimately enables them to live healthier, happier and more fulfilling lives in the place where they choose. Now, within a hospital setting, we work really closely with our health partners to deliver that intermediate care offer with the aim of re-abling people to help them to regain their independence wherever possible. For some people, of course, the assessment process will evidence a need for longer term care and support provision, and the requirements for periodic reviews of the care and support provision and plans that we help put in place. That long-term provision may include domiciliary or residential care, or it may involve offering people direct payments instead of having care services organised for them, so that they can use those payments in whatever way best suits their own needs and helps them to achieve their own desired outcomes. And that's where you may be looking at, personal assistance, micro providers, etc. Additionally, of course, adult social care plays a critical role in safeguarding adults at risk and supporting effective transitions, primarily from children's services into adult services. And we also have a key role in that commissioning activity, that market oversight and quality assurance. So I hope that introduction to adult social care that we designed helped you to try and better understand the extent of our work and what will be the focus of the new independent care quality assessments of care at local authority levels, which commenced nationally from April 2023 for the first time in over a decade since we've been scrutinised and independently inspected in this way. The regulator, the Care Quality Commission, was given these new powers to support greater understanding of the quality of care in local areas and systems in order to offer the public and scrutiny committees such as yourselves much greater assurance and to help them roll out the published interim assessment guidance, which we've included as links within your papers. Work is now well underway on 5 pilot inspections in councils right across England. That includes Lincolnshire and Birmingham. These assessments will focus on how local authorities discharge our duties under the Care Act and will focus on 4 overarching themes. Number 1, how we work with people. So that really picks up how we assess people's needs and support people to live healthier lives. Number 2, how we provide support. And that's got a very strong focus on commissioning, on care market shaping, and how we work effectively in partnership with others, including health and providers. Number 3, how local authorities ensure safety within the system. So that not only includes safeguarding adults and the Safeguarding Adults Board, but also includes safe transitions, safe pathways of care. And finally, theme 4, which focuses on leadership. And that really puts a big emphasis on governance of adult social care locally, on how we're managing risk and scrutinising and sustaining our services. There's also a big focus in there on learning and innovation and how we're continuing to drive improvement. So I think we'd say that as a local authority, our adult social care service really welcomes this new external scrutiny of its activity. And we've been working really hard to prepare both staff and key stakeholders for this additional new focus of future inspection. We've identified senior theme leads for each of those 4 themes on the slide. And we've been working hard to develop and maintain a self-assessment against those CQC quality statements and evidence gathering. To further support our preparedness, the service has invited independent representatives from the Local Government Association, the LGA, and from the Association of Directors of Adult Social Services, ADAS, to observe and contribute to some of our regular internal sessions focused on our performance improvements. We will also be inviting a Local Government Association Assurance Peer Challenge event, with the aim of that taking place sometime in February 2024, which will help us to scrutinise our own performance much further. And as Mel mentioned at the start of this committee, we wanted to stress the importance of elected members really acknowledging the significant contribution and role that you will play in supporting CQC assessments in future. The regulator will be seeking feedback from members of the council, in particular the leader of the council, the executive lead member of Adult Social Care, Dean Ruddle, but also you as members of the Scrutiny Committee and of the Somerset Board as well, that help to oversee and drive adult social care locally. So you as members will be expected to be well briefed on the CQC framework and familiar with the focus, context and performance of adult social care here in Somerset. And I think it's really important that we help you as elected members acknowledge the significant contribution you'll play and have the information you need to be able to confidently talk about how we're performing. The regulator will be seeking feedback from members of the council, so we're really keen that you're supported in this space. And it may be, as Mel said, we could arrange some masterclasses or sessions, perhaps in November or December, to help better prepare you for the LGA peer review in February. In addition, around assurance, we've recently finalised and published our annual report for 2022-23, and that's been shared with you in full as Appendix 1. This is the first time we've created something quite as detailed, but we really wanted to set out very clearly the national and local context for adult social care, including demographics, our performance, demand pressures, and our care workforce planning considerations. For the first time, we've sought to include a sort of self-assessment to go against those CQC framework themes, but also try and capture people's own experience of care here in Somerset through some of what you outlined around complaints, feedback, and staff feedback as well. And we really hope that this helps you in providing a helpful and transparent overview of our work, as well as other stakeholders who may be interested. You'll see from the contents of the annual report that it encompasses a great deal of information about what we do, how we're performing, where we were at the end of March this year, and what our future intentions were set out as being. And we hope, as I say, this will serve as a valuable resource for you. And then looking to the future, in response to our ongoing self-assessment and continued internal improvement plans and aspirations, we've also published a public-facing strategy for the next 3 years, and that's set out in Appendix 2 with your agenda. It sets out clearly our 4 key priorities and commitments, which have been informed not only by an analysis of our performance, but also heavily informed by engagement with the public and also with our own staff. So I've tried to rush through that as best I can to allow time for questions and comments. You'll note that the cover report with the agenda today really asks that you scrutinise what we've shared with you today and consider whether you wish to make any additional recommendations arising from the report or our appendices and any wider discussion. So thank you. I'll stop there and stop sharing my screen so we can have an open discussion and take any questions.
Thank you very much for that, Nikki. That was an excellent delivery, excellently timed, and an excellent report. So thank you very, very much. And you're definitely better looking than Dean Riddle. So yeah, that's much better. Definitely. So that's really good.
Quite a long way.
Okay, members, is there anything that you would like to ask Nikki, please? I think the report is really detailed, and I think it's very, very helpful. And I think we need to know as a committee our contribution to the CQC assessment of social care, and I think that's really good. It feels to me like the checks and balances are in place and they're heading the right way, and that's really good. That is reassurance, really reassurance. So thank you so much for that. Does anybody have any questions, please, or are you happy? Oh, Councillor John Bailey's not happy.
No, no, well, I won't repeat your comments because I thought it was an excellent presentation, and it had an index at the start which gave me a map of where I was going to be travelling through. So I just question really reports that come through from the rest of the reports that come through. They never have an index. They launch straight into something. Is it possible, without really frightening officers so much that they disappear over the hill, that we could have an index that says this is what's going to be in here, and it's a bit of a map? Then you could just say, oh, well, I want to look at 7 or whatever it is. I don't think it'd be too much, but perhaps it's possible. But I've seen lots of them today, and so thank you, Nikki, for an excellent presentation. There's an awful lot of stuff in there, and you did an amazing job to see that. And it's down to me now to read it all. But I do have the confidence that there's, you know, the systems are there to give us the feedback and involvement and consultation. You know, the proof of the pudding's in the eating now. So thank you very much.
Thank you. I think the graphics as well always make it more exciting, always make it more understanding, and I think they've done a very, very good job indeed. So are we all happy then? As there's, that we're obviously, we've considered the updates onto the adult social care assurance developments activities. We acknowledge our key role as a committee in contribution to the new CQC, Care Quality Commission, sorry, no acronyms, and an assessment of adult social care. So if we're happy with that, everyone, can I just have your agreement that you're happy with the report and you don't feel there's any more need for anything else to be added to that? Can everybody show, please? Everybody happy? It's always good to wave your arms in the air. Thank you so much. Thank you. Thank you.
Thank you very much.
Thank you. Okay, right then, we go to our last item on the agenda, which is Healthy Western. Pardon? No, Rosemary, Councillor Woods, no words, please. Healthy Western, okay? Beatings will occur. Okay, so this is, oh no.
Sorry?
No. It's a verbal update. It says a verbal update. Right, okay. So this is me now, okay? So as the chair of the Scrutiny Committee on Monday this week, I had a very useful meeting with Paula Clark, the Executive Managing Director of Western General Hospital. And I have to say, she came really armed with a lot of information. The report covering the Western strategy, Healthy Western strategy and up-to-date information has been on the committee's agenda for a while. I appreciate that. And much has changed since they last appeared before the committee, not least part of the University Hospitals Bristol and Western in April 2020, which I have to say, I have to declare, we weren't aware of that. So the main driver for the creation was the opportunity to deliver sustainable patient benefits through improvements in patient safety, clinical quality and outcomes, as well as improvements in the experience of patients, carers and staff. And I will share with the committee some useful information about developments and have agreed that in February, because it has to be in February because of our tight schedule, the committee will have a report for discussion on the business case for future models of care. The relevance for this committee is that 20% of people using Western Emergency Department are Somerset residents, and it's therefore important that we are kept up to date with improvements that are made. The one thing that I did get from the meeting was the confidence. They feel much more confident about Western Hospital. I myself had some experience of going to Western with my father. It was not good, and I shared that with them. So I think they are definitely, things are massively improving. They're going to, what they've done is that I've asked them to get together some reports, some details. We need some analysis. We need something tangible to bring to the committee. So that's what I'm going to do. But I just wanted you to know that we've had this meeting with the new change, and I can see the change is definitely for the better. So I would like to hope that you're happy that this report will come back. But they need to gather that all together. They need to, some of their assessments are not going to be completed until after Christmas. So I think it will make sense for us to have this come. But it's on the agenda. We've got it and we're on the mark. So we're not going to let it go. So I hope everyone's happy with that. Any questions? Everybody happy? That's good. Okay, well, with that, I'd like to apologise for this lengthy meeting, which should have finished at 12:20. But I think we had the presentation, which I think was very, very valid. So forgive me.
Just a quick point, if I may. I just wanted to pass on positive feedback to Mel, Dean, team on the communication that we're getting and how challenging it must be for you all. And, you know, I don't want to say well done because it's kind of, it's not really the right phrase but it's so challenging what you're faced with, but to deliver the information in the way you are, it's really appreciated.
Very kind. Can I say, we do appreciate the team, we're a brilliant team. And this brings me to my next little thing. I just want to tell you this. There has been some talk about having monthly meetings. The problem is with having monthly meetings is that you're not giving yourself, the team, enough time to get together the right people, to come in with excess. I prefer to have every other month, but if there was a situation where we have a forward plan, where we know we could meet earlier for a subject area, then I think we should do it. But I think we have to give enough time because we're a scrutiny committee that needs professional people to come in and answer our questions. So it's not me dipping out of the workload. It's me actually realising how big the workload is. And I think that needs to be assessed properly. I've spoken to the leader who also agrees that he didn't know where this came from on monthly. But there may be a situation where we do need to meet, and there may be one, but what I think we need to do is make sure we give everybody enough time, because you've all got busy diaries, and I know that. Are you happy with that approach? Councillor Woods. And me included. I mean, like you all, I'm on a lot of stuff, and I think at the moment we have got one put in for September. The September one will still carry on, and what we're going to do is we're going to meet up and find out whether we just get to October, and then we start doing it every other. Maybe that's what we've got to do, but we will absolutely make sure that you are forward planned and you know what's going on. Absolutely. Councillors Pearl. Name. I don't know why I forget it. I do apologise.
Right. Don't worry. Thank you. I personally am probably in agreement with lots of people that bi-monthly would be sufficient. However, I would like to think that we could possibly extend the time frame so that we do have the opportunity, should there be sticky subjects within that, seeing as it is only every other month, that we have the time to question and get fuller answers and not feel pressured by that time. So maybe a bit longer than sort of 3 or 4 hours would be worth looking at. I think that our residents deserve that.
I think I do agree, but some members say that they're too long. So I'm in a little bit, I can't do right for wrong, really. So, but what we'll do is, the idea about having monthly was you would have smaller meetings. But then I think, as you can see, we're not a full house today. We haven't been a full house at all. And I know there's really important reasons why some members can't be here today. So I do respect that. But I think what we need to do is we need to be able to prove that we do need that. If it can always be assessed again, always be assessed. I do agree. I think we try to put a timer on so that we give equal time to people. I think that's what it is. What we didn't do, Mr. Bainbridge, today, he was only supposed to, as a summary, he was summarising for the next one, but absolutely take your point. There will be some things where we can shorten the time. Presentations need to be given enough time, and also you need to be able to answer the questions that you want. So I apologise if you think that that's not perhaps gone to how you wanted it today. I've tried my best.
Should it be only bi-monthly, then the chances are that we will need to scrutinise in a better way. That's what we're here to do, and we need to take that job incredibly seriously on behalf of 550,000 residents of Somerset.
And I thank you for your input today, because I think there's no doubt about it, the committee that have been here today have been brilliant, and you've answered asked great questions, really good questions. And I think that's really important, that you've played a real key role. So I thank you for that as well, because it just makes my life a lot easier. So we'll see how it goes. We've got one in September, I think, and then we're going to work it, and then we're going to give you plenty of time, and if then the committee says, no, we want this, it's your meeting, it's your committee. So it's up for you to tell me. But what I'm concerned about is our staff, they are human beings, and for them to, I mean, you may not have known that. Yeah, they're not machines, so I'm a bit concerned for them as well. That's what I'm worried about. Okay, all right, Councillor Bruce.
Yeah, thank you. I would really struggle if we're having meetings longer than 3 or 4 hours, just for work reasons, for myself, stamina in terms of how much we're dealing with some really complicated, complex topics, and longer than that, I don't think we'd be able to do them justice. Can I also ask, when you're scheduling the meeting dates, can you check? I know it's going to be very difficult and complicated, but to make sure they don't conflict with other, like a day when there's a planning committee meeting on, because having 2 meetings like that in the same day, please no.
The team are absolutely brilliant. They will. I mean, we have decided there's some meetings we may have to do in the middle of the night, but you know what? You've got nothing else to do, so what? But the thing is, no, they'll always check that as well. They're really, really good. So don't worry, because you, like me, we're both on a particular committee where there's 1 a.m. and we got to get back. So and that was unfortunate, but that won't happen again. That was just that one. Okay, sorry about that. Okay, because anyway, Councillor Oakes wants the last word, but he's not going to have it because I am.
Of course. Thank you, Chair. Just that the point is that actually an awful lot in the last 12 plus months has been introductions to things. For most of us are new to this authority and in some cases kind of new to the previous authority. So there's been an awful lot of overview, general sort of thing. Whereas we're now getting to the point when we can properly start scrutinising things and drilling right down. So it will be possible to spend a feasible time, because hopefully we'll be able to lose some of that, so we're more focused. But we will need to be focused and disciplined, because there are some big issues that we need to address. And if we're going to meet every other month, they're going to be tough sessions, and we're just going to have to ask the questions. And to make that work, the other thing we're going to need as members will be that as much as possible is with us in advance, so we can go through those papers, so we're better prepared ourselves to put in those challenging questions that we need to ask.
Obviously that goes without saying, and I make certain, you know, quite honestly, I mean, that's inevitable, that you must have paperwork, which you would do. The committee will look after us, and I really thank them all so much, especially this Jenny beside me, and now, I mean, and you know, absolutely great, and our democratic teams, always essential to us, making it good. So we will carry on, and we will get better and better. So thank you so much for your time today. Thank you. Bye-bye.